Well, just make sure I'm on record. Good morning, everyone. Welcome to one of our add-on classes of our NURS 0420 Bridge course. And we are going to begin now. I am so delighted that we were able to offer this Zoom presentation, and I thank you so much for joining us. And I want to thank Dr. Tierman from Trent for allowing me to use her Zoom so that we could get this out to everyone. The road conditions are very bad, and so I'm glad that nobody's traveling, although we have had somebody come. So I now have officially somebody in the classroom and in the front row, so I'm feeling very special about that. Anyway, so today I'd like to talk about today we're going to talk about critical inquiry. We want to finish up that lesson, and then we want to move on to the advanced practice rule, and those will be lessons 9 and 12 that we'll be able to complete today. We'll go over the high points. I want you to feel free just to pause me, take a break whenever you like, because I'm going to just keep on talking, and you're more than welcome to take a little breather and go and grab a coffee. And in the meantime, I'm just going to pull up my presentation now for critical inquiry. It's just going to take me a minute to share my screen. Now let's see if I can get that up. If I can, yeah, I want to share screen. And it's not sharing, so I'm going to have to go back and I'm still not seeing where I should be sharing my screen, so I'm just going to wait for a minute here till I get all of my presentations up. I'm going to go leave this screen, and I'm going to make sure I've got this going, which I do. Let's just try that one more time. And I still do not see it. But nope, that's not the one we want. We want the other one. So I'm going to stop my screen share. Thank you. You might want to just refresh your coffee while I get this going. I'm going to actually come out of this other one and let's see if that doesn't work better this time. Well, I'm not 100% sure that worked any better. Let's just, I think probably it's my laptop because I have too many. Here we go. I think I found it. So let's, there, I think we're good. Okay. And so, just again, thank you for your patience here as I get used to the technology. And so, we're going to talk about critical inquiry and critical thinking in nursing practice. So, pull out your PowerPoint slide if you'd like, or just sit back and listen. You'll have this available to you. And so, the objectives for this session are to define knowledge translation and understand the significance to practice, to differentiate between critical inquiry and critical thinking, to discuss the role of the RN in relation to critical inquiry, relation to critical inquiry, delegation, and related to the complexity of patient care, and to apply critical thinking skills to various case studies. So, how do we actually define critical thinking? And so, we actually start right at critical inquiry, or to inquire. So when we talk about inquiry, and we will refer to the stance of inquiry quite often, to inquire is to investigate, to eagerly seek knowledge, or to question in great detail. And I think that talks a lot about the stance of the RN. And so the RN is always going to be looking at that, looking at multiple perspectives, always asking that question, what else is going on here? So it's really to investigate, to eagerly seek knowledge, and to question in detail. And so as you are mulling this over, this sort of what is critical thinking, how does it relate to critical inquiry, how does it relate to clinical judgment, there's all these things that we need to consider. And I'm not sure why my little man is not loading, but as you know, that's what it looks like. We have all this input going into our brain, so there's this multiple sources of data, but it's up to the RN to really start to synthesize that, looking at patterns, and then making some kind of sense of all of that data. And so this is what this was supposed to be, all these cogs in the wheel turning as this data keeps coming into our brain. So thinking about the philosophy of critical thinking and critical inquiry, these are some terms you're going to hear a lot of in the next 4 years. I know even as a doctoral student, I always have to stop and think, what does that big word mean? So again, become familiar with it. So epistemology is the meaning of knowledge, or what is the nature of knowledge? What is knowledge? And so that is the epistemology is that branch of philosophy dealing with the nature of knowledge or the theory of knowledge. And you'll hear a lot of terms around the epistemological perspectives or the epistemology of learning. And so the epistemology is actually that branch of philosophy, sort of looking at it through that lens, dealing with the nature of knowledge. Ontology is another term that you'll hear a lot about, and it is the meaning of being. So ontology is the study of existence and is concerned with the nature of being. So if you think about nursing, how does that speak to me in English? Well, what that means is that what is knowledge? And it's taking it right back to those philosophical roots. And the ontology, the ontological perspective is that study of existence. And so how does that play with what our role is as a nurse? So the goal is to think about what is important in the clinical situation and make those decisions and effective, and to make decisions for quality and effective nursing care. I like this model. It comes from the INACSO clinical simulation in learning. They have this in their glossary because it's hard to think about all these different terms that we hear: clinical judgment, critical thinking, clinical reasoning. How does it all relate? And I like this model the best because it shows how everything is interrelated. So you have to be able to problem solve at the very fundamental level of critical inquiry or critical thinking. You have to be able to do some problem solving. And again, you know that when I speak to you about problem solving, one of the earlier models that I use for problem solving was simply the nursing process. So I'm going to assess the situation. I'm going to think, what's going on here, because based on my assessment, do I need to make further assessments? Then I'm going to plan, make the intervention, and then evaluate if my intervention was actually effective. So problem solving at its very basic is sort of the foundation to critical thinking and clinical inquiry. You have to have some development, some level of skills. So psychomotor skills are some of those skills, but other skills as well. Communication skills, interprofessional skills. So you have to have a level of capacity to develop these skills to a level of expertise. And so these are all interwoven: critical thinking, clinical judgment, and clinical reasoning. So I like this model. It helped me to understand how they all connected. Oftentimes you'll hear these words used synonymously, and they are very distinct for our purposes. So we're talking about critical thinking, which is the purposeful, informed reasoning, both in and outside the clinical setting. So we often think about critical thinking being clinically related, but as you know, we do critical thinking at all times in all aspects of our life. And I suspect the process that you use on an individual level will be the same sort of process that you would use in the clinical environment. It is a process, and that's the one thing I wanted to emphasize. It is a process. And so critical thinking, again, basing on those problem solving, if you think of it as sort of hierarchical, the next level would be critical thinking, which is purposeful, informed reasoning. So you would actually seek out that knowledge to make it purposeful. Critical inquiry is the individual instance of nursing practice as the basis for developing knowledge and improving practice. So that whole process of making informed decisions, and that critical inquiry is that always asking that question, for lack of a better way of formulating it, why? Why is it like this? Why is this patient having a rash? And then you start to think, well, what's different? So really, that stance of inquiry, and that's one of the things that is so fundamental to RN practice. Clinical judgment and clinical reasoning, again, at a higher level. It refers to the using critical thinking in the clinical setting, for example, determining the health challenge, giving opinions, and really, I'm going to say that term opinions is sort of, I use it loosely. It's not opinions. We don't give opinions, or we don't say, I have a feeling, but we base it on evidence. If you call up a physician and say, I have a feeling that this is a reaction to the penicillin that they received this morning, what are they going to say? Fine, thanks, hang up. But if you say, I've assessed this patient, and 2 hours after receiving penicillin, this patient has a generalized red rash, they're going to listen to you. So again, it's that critical thinking. It's making the determining the health challenge, giving those opinions or the assessment, and making patient care decisions. And I just wanted to highlight that in no way do I ever want to say that in RPN practice that you don't use critical thinking or higher levels at all. I'm not saying that. And when I do lectures for the RPN programs, that was one of the things that was on my PowerPoint slide that said, that RN practice is really at a higher level of critical thinking and critical inquiry. And I don't think for 1 minute that RPNs do not use critical thinking in their day-to-day practice. I don't think that at all. However, at the RN level, it takes us to those higher levels of critical inquiry and critical reasoning, clinical judgment. So it takes it to a higher level because that's the expectation. Now, as we all know, that many RPNs that have been in practice for 10 years have a wealth of experience, and you'll see in subsequent slides that critical inquiry is based on experience, that you don't, as the RPN, think at that higher level. But that's not the norm nor the expectation. So the RPN is expected to practice critical thinking, the reasoning in which we analyze, clarify, and explain assumptions, evaluate conclusions, and seek to justify the facts and values. So that is sort of what the CNO has said about critical thinking for the RPN level. However, the RN level critical inquiry is a process of positive thinking and reflective reasoning to examine ideas, assumptions, principles, conclusions, beliefs, and actions, all within the context of nursing practice. It really gets to that level of that spirit of inquiry, or you'll hear us repeat it over and over again, that stance of inquiry. It's looking at that discernment and how do you get that patient with the rash? How do you look at the rash being a penicillin allergy as opposed to maybe it's a set of NURS, maybe it's the bed sheets that have some kind of fragrant Tide solution in it? How do you make that discernment that this is really probably due to that penicillin the patient received 2 hours ago? It's logical reasoning. And so as you look to developing this critical thinking, and I was at a seminar this week, and it looked at some great models that when you do your assessments of your patients, that you're looking at these alternate, and nurses don't diagnose. So we don't, that's not part of our role of practice, scope of practice. However, if you are very narrow in your focus, you're going to miss all these assessment parameters. So as you're doing it, and as you develop this critical inquiry, you're doing all kinds of assessments. So one of the examples I have is a patient complaining of chest pain. If you automatically assume this, and again, I guess if you automatically assume this was chest pain, or myocardial in nature, and I do say that we always assume it's myocardial in nature until we prove otherwise, but you need to do a full assessment and assume, yeah, my highest priority is that this is a myocardial infarction, we need to act quickly, but also it could be GERDs. And how many times in the CCU have I had a patient say to me, I'm having chest pain, it's crushing, quick nurse, quick. And I grab the ECG machine as I grab my nitro, and I run back to assess the patient. As I sit them up and they belch, they feel better. So really, but however, I assume that it's that, but I'm going to do an abdominal assessment, I'm going to do a respiratory assessment to rule out anything else, so that when I do report on my assessment findings, I have a full picture. So really looking at that, other things that you need to discern, logical reasoning, and application of critical thinking standards. That is what the CNO is expecting for RN practice. So knowledge translation. And so as we move to knowledge translation, which is another hot topic, and if we have time, I may play a really great little YouTube video that one of our Year 2 students put together for knowledge translation. It was really well done about how you actually take the knowledge that you have here and you translate it into practice. As we know, there's often a gap in that area that although we are teaching you how to practice nursing in an evidence way, an evidence-informed manner, it often is lost, the proverbial lost in the translation is often lost as you apply it in clinical because of a variety of reasons. It could be because the hospital has not adopted that practice, because they're not incorporating evidence-based. They're not at that higher level of knowledge translation. And we talked about that knowledge translation takes sometimes 8 to 10 years to really get that evidence from bench to practice. So knowledge translation does take some time. It may be that you're just too busy with your practice, that you've got 6 patients on a busy med-surg floor, and you just don't have time. You just got to get the work done. And so I'm going to suggest to you that you always need to be including knowledge, evidence-based practice. So knowledge translation for our context is a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health of Canadians, provide more effective health services, and produce and strengthen the Canadian healthcare system. And that's from the Canadian Institute for Health Research, and that was a 2012 reference. And you'll know that this is not just applying to nursing. This is every facet of healthcare. There is a real lag for knowledge translation, but this is what our working definition will be. And so I just want to emphasize that. And one of the examples I can give is the CPR standards. So you know that we have BLS, ACLS, PALS, and all of these evidence-informed, evidence-based standards that we have to adhere to. So for instance, BLS is now, we need to get recertified every year, and that we have to include all of these evidence-based steps. So for me as a BLS instructor, I have to adhere to the heart and stroke. They give me all of the materials that I need to teach so that I am adhering strictly to what the evidence is. And so, but as you know, evidence comes out all the time, and so it is a dynamic process. It's something that is always changing, and it's an iterative process. So it's always this will be the practice right now because this is what the evidence supports. However, as new evidence emerges, that may change slightly. So an example was we did compressions at 100 per minute, and that came out in the 2010 guidelines, if I'm not mistaken, or 2015 guidelines. And so now we know that we can go up from 100 to 120. It's better just to be a little bit faster than it is to be slower. If you're less than 100, it doesn't work at all. You might as well not do anything, but 100 to 120 is quite appropriate. And so that's how the evidence has evolved. And so it is a iterative process that includes the synthesis and dissemination and exchange of ethically sound. So yeah, maybe doing compressions at 120 per minute is the correct thing to do, but maybe they decided that using those automatic CPR machines would work. However, there's some error with them, so maybe that's not the most ethical way, or maybe not everybody has access to those. So we need to make sure that it's ethically sound in that knowledge translation. And so as we move forward to the model of knowledge translation, this sort of depicts how we apply knowledge, that it is really evidence informed into practice. So it's the process of moving knowledge generated into practice. So it's all of the evidence that has come to fruition. So we have our doctorally prepared and master's prepared nursing staff, and they're engaging in so let's for instance say how students learn. And so they'll delve into the research. They will ensure that it is sound, ethically sound research, and then they will disseminate that for everyone to incorporate into their settings. So as you can see, knowledge translation, it's sort of overarching is the healthcare setting, and that healthcare setting can be acute care or chronic care, community care. It could be any facet of the healthcare setting. And so as we see in this slide, we have that knowledge creation. And we talked about that when we did our section on research, and we want to make sure that it's always rigorous, that you're always asking yourself, is this sample truly reflective of who they're saying? So nursing students is a large population, and so is this study of 5 students really depict the entire student population? So again, thinking about knowledge creation, so that evidence is created, and then now we have to get it to the end user, and that's where we're falling down. It's really difficult to incorporate some of these changes into practice, and as you know, nurses are in practices we're knowledge brokers, and so how do we incorporate the latest evidence? And oftentimes we are restricted by our own institutions, lack of policies and procedures, lack of buy-in from our leadership. But yeah, don't worry about that. It costs too much. We don't need to do it. And in fact, it would be benefiting the patient. So knowledge translation is applying that knowledge that is evidence-informed into practice, and the process of moving the knowledge generated into practice. Okay. Is there any questions? I'm going to first go to online. Please use the chat function. If you have any questions, I'd be glad to entertain those now. Any questions from my lovely front row people here? No. Okay. And if we're going over it rather quickly, please stop. It's for the benefit of those at home as well, and you'll have access to this recording, so you can play it again if you've missed something. Okay. So I didn't see any questions in my chat feature, so I'm going to move on to Delphi report. And so we talked about some of these research studies, and so one way of doing where there's little evidence is what they refer to as the Delphi method. And so this Delphi method was an attempt to define critical thinking by consensus. That in itself gives me the chills. An expert panel of theoreticians representing several disciplines from the US and Canada developed a conceptualization of critical thinking in the late 1980s. And so what that means is that for critical thinking to occur, how that occurs is that you have these experts in the field. They will then they'll define critical thinking. They'll ask some questions. What is your definition of critical thinking? How do you apply critical thinking? So some key questions. They send it out to everybody, and then these experts will actually look at them and try to make these into themes. So they may take these 30 responses, and they'll collate them maybe into 5 main themes. And then from those 5, they may even synthesize that even more. But however, they will take it back to the experts to make sure they're not losing anything in the translation. And so 55 nurse educators were to obtain consensus with the definition of critical thinking. And so as a result of that, they were able to actually drill that down to 17 dimensions. That's brilliant, because I did not think that they would be able to do that. And so just as we move forward, when I say critical thinking, what is your own definition? So I want you to take 30 seconds and just think, when I say critical thinking, what does that mean to you? What does that conjure up in your head? What do you think of when I say critical thinking? So just pause the tape right now, pause the presentation, and think about that for a moment. Okay, so moving along, and so when I look around the room, what do you think about critical thinking? When I say critical thinking, what do you think of? First response. How about you, Sal? Excellent. So critical thinking is sort of analyzing at a deep level, which is going to be the best outcome for that patient, and then selecting that. So not only just sort of thinking, yeah, this would be the best thing, but we always do this. It's really selecting the best outcome. And yourself? Exactly. It's thinking outside the box. Absolutely. And that's so important. So an essential component of critical thinking. And so these were some of the dimensions that came out of that Delphi report from those critical educators. And so and then as the experts sort of worked with all of the data, they added their own. So an essential component of professional accountability and quality nursing care is critical thinking. And so critical thinkers in nursing exhibit these habits. And what I like about that statement is habits of the mind. So it's all about thinking. It's that metacognition. And so it's confidence, it's contextual to that patient situation, it's creativity. And how many times have we had to be very creative in our solutions? And that is a good example of critical thinking. It's being flexible. So we know in Potter and Perry, it tells you these are the steps you're going to use. However, for this particular patient, that wouldn't work, and you need to make it within the context of that patient. It is having that stance of inquiry, or that inquisitiveness. So why is this like this? How did this happen? Not in a negative way, or not, and nothing frustrates me more than when my clinical instructor would say, well, why? Why? You know, but helping you to uncover at a deeper level. So tell me more. What are you thinking? How did you come to that conclusion? What were the pieces that you assessed? And so helping people to uncover and coming into that stance of inquiry. Open-mindedness. That's a really huge thing, because we know the way we've done it for years and we like it that way and it works for us, but really being open to new suggestions. And so that's really that is really critical thinking. It is that intellectual integrity. So you're thinking that's another one of those big words like epistemology and ontology. However, that intellectual integrity, to think, it is helping you to think about that process of thinking, or that what they refer to as metacognition. And interesting enough, I had one of those light bulb moments, which is critical thinking. I had one of those light bulb moments this summer when I was at a conference, and I was the keynote said, metacognition, or the ability to think about thinking and learning and knowledge, doesn't really develop till after age 30. So for the bridgers, I think a lot of them are closer to that age group than some of our collaborative students. And so when we give the collaborative students the same, just go and read the book, and do your pre-reading before you come to class, they don't even know what to read. Whereas the bridgers, because of their maturity, the ability that they've already developed this metacognition, they can go to the textbook and they'll know what they need. They don't need to read everything on the assessment. They know that piece, but they know where they need to go. And they can make a detailed learning plan for themselves. So it's that ability to develop metacognition, or that intellectual integrity. It is perseverance, and I'm speaking to the choir here. If anybody has perseverance, and I'm not even going to say develop, but if anybody has perseverance, it's the bridgers. That is they're tenacious in their quest for education. I can say that 100% of the time. 100% of the time, they are tenacious. They persevere. I mean, we've got people here in this class already, and I did, mention you could stay home if you needed to, or the weather was bad. No, people are here, and so I commend you for your perseverance and that tenacity to seek out further education and that lifelong learning, and reflection. And I think also that you've developed a formal process of reflection, and that helps you that helps you in your critical thinking. So critical thinkers in nursing practice, the cognitive skills of analyzing. So they develop that ability to analyze at a higher level. So what's going on here? Why is this like this? Or I need some help here. So really that ability to analyze, applying standards. So as you know, there's different standards. There's the standard, best practice guidelines as standards, there's other standards, there's educational standards, there's nursing practice standards, there's BPGs. I'm sure everyone's familiar with BPGs. There's all of these standards, and you're aware of how those standards play with your, have a role in your practice. You're able to discriminate, and one of the illustrations I love, and I'm going to make a YouTube video of it. And if I could just have you think about, I don't know if anybody watches that show, Hawaii Five-0. I went to Hawaii and I loved it, but also when I was growing up, I loved the old version of it, so it just makes me feel like I'm back in my youth. So Hawaii Five-0, and if you see that they have a center console where their computer is all glassed in the center table, but they have a whole wall of data, and they pull it down, I need that, they move it along, pull that down. And that's like nurses today. Because of the way that data comes at you, you're able to discern what you need to make it the best possible solution for that patient. And if there isn't data there, so for instance, you're giving your potassium and you're thinking, oh gosh, I don't have potassium. You're giving furosemide for someone in heart failure. And the first thing that comes to mind is, what is the potassium, before you actually give that. So really looking for the information that you need to provide safe care, logical reasoning, predicting and transforming knowledge. Predicting is that, well, if I don't do that potassium replacement, this patient might become hypokalemic. So really thinking about, and that anticipatory thinking. Critical thinking and clinical judgment. And as we mentioned, we sort of have problem solving at the bottom, then we have critical thinking, and then we move up to clinical judgment and clinical reasoning. So clinical thinking and clinical judgment are guided by, are outcome focused. So always looking at the end result. That's part of the reasoning process. It's driven by the patient, family, and community needs. So while the policy says this is what you need to do, you sometimes need to make minor modifications. And we talked about that during the research that if a patient says, no, I don't want to stop smoking, the evidence says smoking is harmful. And I'm sorry to pick on you smokers. We know that smoking is harmful to you. And so we are always doing health promotion strategies. But if they don't want to stop smoking, in the end, that's their choice. And so it's really driven. And the critical thinking piece is, how do we provide information just to plant the seed, maybe at some point that the patient would be interested in quitting smoking or smoking cessation. So it's the ability to focus on thinking to get the results needed in various situations. It uses reasonable and reflective thinking, and really to avoid that rote memorization. So as you go forward, when you're in clinical practice and your clinical instructor said, why did you do that? You have to have a rationale. Everything in RM practice, there's a rationale, and it should be at the tip of your tongue. Even if for everything, we need to have the rationale as to why you've done a procedure that way, why you have planned to do the procedure at that particular time, how you prioritized your patients. It is all of those things. And so it can't be just rote memorization. And a good example of that is when I was teaching another Bridger group. It was level year 4 synthesis group. And so I said, patients having an MI, what medication does this patient require? And they said, well, the patient needs aspirin, they need TNK, they need a beta blocker, they need a statin and a laxative. Okay, why? They did not understand the rationale, because your programs don't prepare you. You learn a lot of information in a very brief bit of time, whereas the purpose of RN education is to really do that deeper dive. And so that's what you have to know, the rationale for giving the medications. Is this the right medication for the right patient at the right time? Just as recently as this week, I asked someone, is this the right medication to give to this patient? Their renal function, it was an NSAID, and their renal function was just at the, the borderline. And so, no, I'm seeing people shake their head, thank you. And so I said to the nurse, should this patient be getting this? And the response was, the doctor ordered it. So we need to think about that. Is this really the right thing for the right patient at the right time? And while one of my clinical instructor colleagues said, doctor's orders are really suggestions, I don't know that I would take them that loosely, but in a sense, we have to determine if this is the right thing for the right patient at the right time. That is what we have to do. And that's based on your problem solving, critical thinking, clinical judgment. And so critical thinking is guided by the CNO standards and code of ethics. And so we all know those practice standards. Again, you probably, the RPNs know them the best because you've looked at them as the RPN level, and now you're looking at them at the RN level. And so guided by the CNO standards and the code of ethics. And I'm hoping that you've all had the opportunity, I think we've done ethics, but if not, making sure that you've had just a brief look at the new CNO standard, not CNO, CNA ethics document. I think I posted a couple weeks ago. There's the new standard. Remember, we were practicing with that one that was from 2008, and while it was still relevant, we still practice ethically. This new document really encompasses a lot more about the role of the RN practicing at an ethical platform. And there's some very interesting ethical dilemmas that present to nursing each and every single day. So, which you're going to have to apply critical thinking and clinical judgment. I won't go into that any further detail. Professor Marianne will be doing a whole course on ethics next fall, and so you'll have a ethics tutorial with all the health science students and doing overarching healthcare and bioethics, and then she does just nursing ethics, because nursing really sees patients at their most vulnerable. And we need to make sure that we are all working from an ethical place. We have ethical comportment, and that we have a strong moral compass. So I just wanted to highlight that. So critical thinking and clinical judgment require strategies that make the most of human potential and compensate for problems created by human nature. So we have to really keep our biases in check, and I'm glad that we're moving from that notion of, well, when you walk in the hospital door, you just become a blank slate, that you put all your biases on the table and you just walk through the door as a unbiased person. That was hard to do, and I think we talked about that. That remember that this is as a practitioner, that is a lifetime accumulation of your culture, your family, your community, as well as your experience. And so as much as you try to just shelve your biases on the counter, you can't. And so the most important thing is that you are aware of them, you acknowledge them, and that you know how other different cultures may intersect with your culture. And so, but again, we applied non-judgmental care, and so we have to be that, have that stance that, yes, well, I might not believe in this, I have to provide unbiased and ethical care to that person who does. So how do I coincide that? And so again, we all have developed some strategies to do that, but knowing that we don't, we're not blank vessels that go to the bedside. We are constantly reevaluating, self-correcting, and striving to improve. So, moving along, critical thinking. And we've talked a little bit about critical thinking. And so critical thinking is a system by which an individual incorporates elements of understanding, problem solving, analyzing to come up with a conclusion or an evaluation. And I think we've already got that one down pat. The ability to compare, analyze, critique, extrapolate, and synthesize information. That's a little bit higher level, maybe even getting into critical inquiry. And they talk about it as being the third eye. It is taking off the blinders and looking around. It is finding the abstract in the not so obvious, and then finding solutions. They say that rational thinking is, and that it's that deliberate mental process of working through a situation, and it's that purposeful mental activity. It may be prompted by reflection, and I think that's one of the things that I learned along the way, because remember, I graduated from a 2-year program. I learned a little bit about everything, and in fact my program was the first year out of the hospital. Prior to that, everyone was in the hospital, and so we didn't, we memorized everything. Quick. You need to memorize the body parts. It was heavily scientific based. There was really little nursing theory, because we really hadn't gotten that far. And so I memorized a lot of things. And then when you go to apply it, because we provide care to such a diverse population, everything is so different than what you memorized. And so that's why it's really important to develop this deliberate mental process. Yes, this is the ideal way to do it, but I'm going to have to make a modification without jeopardizing quality. So that is part of critical thinking. And really to think outside the box, as you've already mentioned, it's really thinking about best possible solutions. I think that was such a great example, is how to get to the best, to take those 2 paths or multiple paths, discern which way is the best route for this patient for the best possible outcome. Okay. I think also part of critical thinking is looking at both sides of the coin. Yeah, this is what the evidence is now showing, but there's also evidence to support this. It's also thinking about the patient. It's always directed by the patient. I'm sure these were all on your list when I asked you, what is critical thinking? And you said it provides that foresight. And I like that term. I like to use the term anticipatory thinking. Anticipatory thinking really comes with that experience, and I think RPNs, experienced RPNs, such as we have in our class, they do this quite nicely, is that anticipatory thinking. Although a lot of times I think that because of the nature of the work that we are doing, that you just get the work done. You don't have time to think, just get the work done. So it provides that foresight, that anticipatory thinking, that you can start to compare, well, this is what the Potter and Perry said, but this is what the patient is presenting. How can we get the best possible solution? It fosters mental independence. It encourages thinking on multiple levels. And that's a real paradigm shift than what our thinking has been in the past. This is really thinking about at a higher level again, is that 30,000 foot view. that is RN practice. So again, another example I can give of that is, so when you have a cardiac arrest, if you're on the chest doing compressions, you can't see what's going on with the team, and you need to have that co-team leader standing back and looking at the entire team. Is somebody managing the airway? Is someone doing effective compressions? Have we got the IV going? Are they giving the right sequencing of drugs? We need someone to step back and look at that 30,000-foot view. We can't have people in the midst of things. And I would suggest a lot of times that nursing practice, you're in the thick of things. You can't see that the higher level. And so it's going to be that deliberate step back and look at the big picture. So I'm going to encourage you that all this, over the holidays, as things ramp up and you're all going to be so much busier at work because of the holiday schedules, I want you to think about critical thinking, and I want you to think about examples from your own practice. But I also want you to step back at one point, just one point. I know you just got to get the work done, but at one point each day, I want you to step back and think, what's really going on here at a bigger level? So you got to get your bed best done, you got to do the transfer, but step back and think, does this patient need to get discharged so they can be home with their family for Christmas? Does this patient need a different antibiotic because when I looked at the sensitivities, they were not appropriate? I'm going to make it a challenge that everybody step back at least once over the holidays and look at the big picture and see if you can push back the box that you're in and push it back. And I know that. I mean, I've been in that situation where I've been busy. Just got to keep going. You're on the hamster wheel. And I've missed things. So you need to step back, and it is deliberate. So just once. I'm just going to ask you to do it once over the holidays. And all you at home in your pajamas, I want you to do the same thing. I want you to step back and look to see how you can get the bigger picture and train yourself to think about that. Critical thinking encourages thinking on multiple levels, suspends judgment when gathering information. If you are thinking that this is myocardial ischemia, I know it is, I've seen it before, and you're not looking at the whole picture, then you're going to miss things, and you're going to miss some things in your assessment. And I can give some great examples from my own practice when a patient was getting a little bit short of breath. A little bit short of breath, I guess. Anyways, looked at his telemetry strip, and it looked to me, I just sort of looked at the monitor, and it looks like sinus rhythm with PACs, and away I went. I didn't pay any attention to it. In fact, it was atrial fibrillation because I did not take the time, and I didn't step back to look at the big picture. It was atrial fibrillation, and it needed to be treated. And by the time that I really made that determination that it was atrial fib, the patient was in heart failure. So again, really taking the blinders off and opening it up to look to see what other things could be going on here. Allows understanding. So there's no right or wrong. It's the best possible outcome for the situation. Comes with open-mindedness, generates one's own views and perspectives, allows for differing opinions. And so while we may agree that this is the best approach, or we may disagree that this is the best approach, we have to come to consensus for the patient. So I can't do this on my shift and you do that on your shift. And so the plan of care has to be established as the best possible outcome for this patient. But again, it would allow for that. No, I don't agree with this, but this is the best possible solution for this patient, then I will do the same thing. Acknowledges different sources. So when you're collecting data, it can come from multiple sources, come from family charts, it can come from past health, it can come from their old chart. So looking to see where that data is coming from. Generates better problem solving, enables better examination and re-examination. And again, I just want to highlight, it's always that re-examination as you are doing that first discovery, peeling back the onion. You see the onion, but let's take off a few more layers to see if that in fact is the onion. So it might be just a leak or something. So always looking at examination and then re-examination. What do critical thinkers look like? And we talked about that earlier, about how the ideal critical thinker is always asking that question. Why? Why is this happening? Or why did this occur? So is this patient with having community-acquired pneumonia? This is their third admission with community-acquired pneumonia. They're febrile. They're an 80-year-old with a history of a stroke, and they've been at home in the community. Their family are taking care of them, and third admission with their pneumonia. What do you think is going on with this patient? And you can type it in the chat feature. So I know that I always prioritize, and I'm going to start with the airway. Is this patient aspirating and because of the stroke? Is this the reason why the patient is not able to swallow and is developing pneumonia? Is this patient too sedentary? Does this patient have enough nutrition? And that's why they're being compromised, because they're not eating well enough, probably because they're not swallowing well enough. And so you see how you start to uncover this whole process. You need to be self-informed, trustful of reason, and open-minded, flexible, fair-minded in evaluation, really being honest in acknowledging our own biases. And I think we talked about that already. And I think they really just want to emphasize that it's a deliberate mental process, persistent in seeking results that are precise as the subject and circumstance permit. So it's really, it's that persistence. That, I'm not sure that was really an onion. I need to go a few more layers to find out what's really going on, and maybe branch your inquiry from the patient. So tell me what you eat. Do you have your teeth in? Maybe they're not teeth in. There's no teeth. He can swallow. It's just he can't chew it. He is now aspirating. So to be a critical thinker, you need to be thinking ahead, and that is a huge thing. Is that anticipatory thinking? I know when I first graduated, I worked on a medical surgical unit, and I thought, I just want 5 years experience. Once I have 5 years, I'll know it all. And so once I got 5 years, I know everybody's like, what's the matter with you? Exactly. Then you just know that you don't know anything. But prior to that, you know everything. But however, you are thinking ahead, and so based on Benner's model, and it was well before I ever knew about Benner, but I knew if I had 5 years experience, I would feel much more comfortable in my role, and I'd have a good grasp of what was going on around me. And so, and also, I was very young, so I was just to turn 20 when I graduated, 20, yeah, just graduated at 20. And so, still very young. We know, as I mentioned, you don't develop metacognition until age 30, so I had a long time to go. And so, as you start to as you develop your practice and you become more experienced, that's when you develop that anticipatory thinking. And so I realized that was occurring, and that's when they talk about critical thinking. I didn't know the definitional terms, but I knew that I had it when I would be going to, with the doctor, to put in a central line in the ICU, a special line into the heart, and it often caused arrhythmias, so I would carry some medication, lidocaine, with me. Then I knew I had critical thinking. So it's thinking ahead and being prepared, and all of those what ifs. So as you're going to do a procedure, what if? Or as you're going about your day, what if the patient has an arrest? Have I got a bag valve mask? That's usually the thing I always make sure I had a bag valve mask. So thinking ahead, being prepared, and being proactive. So I had a patient admitted to the ICU, and of course, I think I've shared with you, I'm an adult ICU nurse. I'm not a pediatric nurse. I took as many day courses and workshops as I could fit in my schedule, but still did not feel comfortable with pediatrics at the time. And then I was working nights, so I was casual, and casual people only go in once in a blue moon. And then it was my turn to take the pediatric patient. My heart sunk. Anyways, it was about 3 o'clock in the morning. I thought, oh wow, got through over half the shift. They're not going to get a pediatric admission. No sooner did I say that, then the emerge called to say we have a baby who was born 3 months early, was discharged from sick kids a week ago, picked up RSV from their older sibling, and was readmitted, and they're coming over to you in the isolette. I'm thinking, isolette? Anyways, they move in, they bring me in this big isolette. I want to say space age, so I thought there was every lights blinking and all this kind of stuff, and probably it's just my imagination. And I am actually pinned up against the wall, pale, tachycardic, thinking, how am I going to manage this? And this baby was only probably about 5 pounds because they were born so early. Tiny, tiny baby. And you could hear all the sternal indrawing and the grunting. You didn't need to be an experienced provider to know that that baby was in distress. So I called the doc and they said, well, get mom to breastfeed. I'm thinking, breastfeed? How can you breastfeed when you can't breathe? But I thought, okay, what do I know about this stuff? So anyways, again, didn't I tell you, you need to be a critical thinker? That should never have happened. Put babe to the breast and thinking, now I'm a lactation consultant. Can't we just run the IV? I can do that. Anyways, babe desaturated within 30 seconds of taking out the isolette, put babe back in the isolette, and called the doctor saying, I think we need to have the sick kids come and get this baby because this is not looking good. And so the doctor was more or less insinuated, what's the matter with you? Can't you take care of a little baby? And I'm like, no, this is not the safest place. And so I called again because I thought this baby would need intubation. We did not have a pediatric ventilator. And anyways, to my credit, I was able to keep this baby going till 7:30, and the sick kids team eventually did come. And the doctor did come in at 7:30, so the 3 longest hours of my life. And they did take the babe downtown for ventilation, intubation and ventilation. And I wish I could have advocated stronger at 3 o'clock. Because if we could have avoided that deterioration of 3 hours, we would have been better ahead or more ahead. So again, it's being proactive. And I share that with you just as a way of saying we need to always be thinking ahead. They have these terms called thinking in action and thinking beyond action. Thinking in action is when you're actually doing something and you think, oh, okay, maybe I should do it this way. Or doing a Foley catheterization, as you all know, what we're taught, we have our sterile trays, we have our bedside table that rolls right nicely up to the bed at the right height, and we open up our trays and everything is done by Potter and Perry. How many people have an environment like that you can put in a Foley catheter? How many people are working in the community where you're putting it in on like a chair beside you or a step stool? And I have to say, one time in Emerge that they wanted me to put in a Foley, and there was no bedside tables in the Emerge department. This was at Sunnybrook. There was barely beds. In fact, there was a few beds. And so they said, well, here, just use this little footstool. I'm like, no, I'm not using a footstool. I need the bedside table. I wasn't using my critical thinking. This lady needed the catheter. So anyways, thinking in action is influenced by experience. So as an experienced community nurse that you can create, hand sanding down a surface, put on your sterile tray, and the principles of sterile asepsis so that you can keep that area clean. Thinking beyond action, which is that thinking back, is when you go back and you reflect. And remember to reflect in a very deliberate way. It's not just, wow, that was a really bad shift. That was really bad, and I don't want to go through that ever again. It's that deliberate thinking of stilling the mind. Remember that, John's model, we're going to still the mind, preferably not behind the wheel, but if it has to be, start decluttering your mind. What's niggling at you? What is bothering you that you need to reflect in that formal way? Something's sort of disturbing me. Then going through that, what was the situation? So really explaining that situation in fullest context, because sometimes we're so used to doing things quick, we don't even explain the whole thing. And once we just actually explain the whole thing to ourselves or narrate the whole event, it's sometimes not as bad as what we think it is. So narrating that entire event, looking to see what were the values, what were the values at play, what were my values and beliefs, how did it intersect with the patient, why did it unfold that way. Was there any other factors that I need to consider? Well, yes, there was no furniture for me or whatever. So think about that. And then for next time, going forward, if this should occur again, this is how I would respond. So it is a step-by-step deliberate reflection, which is that reflection beyond action or after action. Generally, that's done quite soon after the event. And there's a new concept that I'm quite intrigued that I will be exploring more, is thinking beyond action. So it's after you've taken and you've done all your reflection, and then, maybe a month or two later, something else could be related, could be unrelated. All of a sudden you have another flashback. This is another thing I want to remember when I come up with that situation. So if something else has spurred you to think about this again, that's thinking beyond action. Remember, this is always it's contextualized. So, just you might want to pause the presentation now, and for those of you in the room, you're free to engage in this, or you can, or not, whatever you'd like to do. So I just want you to think about a time, just very briefly, think about a time when you have demonstrated that thinking ahead, or thinking in action, and thinking back, or thinking beyond, thinking after action. And as you're thinking about that, think about the situation and describe how you would have demonstrated all three ways of thinking. So think about an event, then you're going to think about when you were in the moment, what did you think about it? How did you think, what were your thoughts? How did you maybe anticipate that you needed to take a medication or do something differently? Then after you were finished with that event, think about afterwards, when I was doing my reflection on that, what were my thoughts at that time? And then think, has there been a time where you've sort of thought months later, the light bulb moment. So think about that for a moment. Okay, and so I just wanted to talk a little bit about clinical thinking skills. So critical thinking, again, we know it's on multiple levels. It's all about problem solving. It's about thinking independently. While we are collaborative, and there was, I read a review this just a couple weeks ago where somebody said they were an independent practitioner prescribing and blah, blah, blah. I thought, how could you be independent? We're always part of teams. However, we are independent thinkers, but we work within collaborative teams. We analyze the facts, we clarify any questions, and so if you're doing your fact finding, you may need to ask physio or the physician to clarify a part of that, something that is unclear to you when you're doing your fact finding. You want to be looking again, take a step back and look at that holistic view, and always be open-minded and use a real sense of reasoning. And if that reasoning process is really the nursing process, that's absolutely fine, because remember, that was the sound process and that was the only nursing theory that I had, was the nursing process, and that's something that we do all the time. Other clinical thinking skills is being creative. It's really looking at the pros and the cons and then making a decision and moving forward with it, but remembering that we always evaluate everything we do, every intervention we do, every medication we do. Remember that that is a key part of our role, is the evaluation. Problem solving. So you need to, I think we've talked about all the process for the problem solving as well. So problem solving is a strategy of critical thinking. It's the process used to resolve or answer any of those proposed questions or to achieve an answer. Decision making is a selection of actions to achieve an outcome. So traditional thinking versus higher level thinking, and again, it's even hard to think about this at a higher level. I know when I was first exposed to this, what do you mean higher level thinking? Thinking's thinking. How much higher can I get? But when you get those light bulb moments, and I guarantee that you'll get the light bulb moments, I've seen it when I teach synthesis, that they'll sit in the front row and go, I get it. Particularly the bridgers, because all of a sudden there's those light bulb moments when it's very clear. Up until that point, it's just like, let me get through it. I don't care. Just let me get through it. And then it will all of a sudden make so much sense to you. So that traditional versus higher level thinking. So traditional thinking is relying on personal beliefs and values, making decisions not based on facts. And we see some of our colleagues that might be doing that, engaging in practice that really isn't based on any kind of evidence or facts. Higher level thinking includes the more abstract thought. And when people start talking in these lofty concepts, my brain just goes to sleep. So I'm hoping yours doesn't. But thinking about abstract. It's thinking about at a larger, it's thinking at multiple perspectives at a higher stance. So you're looking down at the situation differently than when you're right in the situation. It's broader thinking, and it's really analyzing those facts to make that better, to have a better outcome. And so think of a time when your experience, beliefs, and assumptions prevented you from seeking an alternative solution to a situation. So just take a moment, of a time when your experience, maybe your own personal beliefs, that assumptions prevented you from seeking that alternative solution to a situation. So just take a moment and think about that. And I think I shared with you that for me, it was that time that I looked at the telemetry strip and just sort of walked, but yeah, that was a PAC. Yeah, walked on by. It was atrial fibrillation that needed treatment. So it's that quick, not really thinking about it, just sort of rote knowledge that, yeah, looks like it. I didn't take it and identify it. Doing a systematic analysis like I normally would. And so really important to do that. And so that's one of the times that I did not use my critical thinking at all, and I got caught by it. Or in the same situation, is a patient did go into atrial fib. I was calling, to me it just looked like atrial fib, and when I called the physician, he asked me I just needed some digoxin ordered, and so I didn't have all of my data. So we have I'm sure you use the same approach, so I use the PQRST format when I do my subjective assessment. And so I just thought, atrial fib, okay, call, and I need an order for dig. And they said, well, what about this, and what about that? Is the patient experienced any diaphoresis? Is there any, what are the vital signs? I didn't do a full assessment. And again, didn't use my critical thinking and got caught short because I didn't have data obtained from multiple sources. So traditional thinking, guessing. I can't even imagine someone guessing, but the odd time, you know, I hate to say it, but, you know, sometimes when I would be in clinical with the year 2 students, they were in earnest. I don't think they thought anything was wrong with it. They thought they knew, but they were just like randomly guessing it. When I'd say, well, what are the side effects of this medication? I think, and it was just really random words. They had no evidence. I said, well, first of all, nurses don't think and guess at anything. It's all right to say, I will check and be back. That is an okay response to say, I'll confirm that and I'll be right back to you. That is okay. So we would never say to a physician, I think that it is blah, blah, blah. You would always go back and confirm your facts, or else you'll lose all credibility. So you want to not guess, or I believe that it might be pneumonia. No, we don't believe. You can assess. I hear, of course, inspiratory and expiratory crackles in the left lower lobe, and the patient is expectorating green sputum. The saturations are. So again, you can look at assessment, but we would never say I believe. Inferring, that's traditional thinking too, that if this happened, then we can infer that that happened, and we don't do that. We want to have all of our facts, all of our ducks in a row. Or offering opinions. We don't offer our opinion to the patient. Yeah, my mother used to serve us all chicken soup when we had a cold. That will work for you. Although I think there is evidence to support that chicken soup does help your immune system, but not strong enough that is prescribed by the healthcare team. Higher level thinking, on the other hand, is around that it's okay to estimate. It's all around evaluation, and I hear that quite clearly from our group, that it's around evaluation. Assuming, and you have to be careful with some of the assumptions, but I'm saying it in the loosest sense of the word, that and so I'm thinking that if a patient has some changes in their electrocardiogram, we can assume that the chest pain is related to myocardial type disorders. So that sort of assumption, but you have to be careful of just assuming generally. Inferring, hypothesizing. So our practice, as you will find out in year 3 or in your middle year when you are in stats, that you'll talk about hypothesizing and how you can hypothesize that this will occur as a result of that. So again, hypothesizing, because to even get to those hypotheses, you have to have higher level knowledge. And then developing criteria, judgment with criteria. critical thinking indicators. And I've got a brief model I just want to share with you, because you know, if you have a conceptual model, for me it helps me to put everything together. So critical thinking indicators develop critical thinking characteristics and behaviors. And again, how do you develop critical thinking? We know it's that problem-solving approach. It's that experience that just by nature of being at work and by getting that experience, you're going to develop critical thinking. But it's that deliberate mental process, and I'm going to suggest reflection plays such a huge role in that. Acquiring theoretical and experiential knowledge, gaining interpersonal skills, and the required technical ability. And as you see that there's all of these, so communication with your peers will help you with critical thinking, as well as that technical ability or those psychomotor skills. And I like this little model, which is the 4 circles critical thinking model. And it gives a picture of what it's like to think critically. So going clockwise from above, here's what you'll need to do. So you need to develop critical thinking characteristics and behaviors. When someone has critical thinking characteristics, the skills in the other circles will become readily apparent. But as you can see, it's all overlapping. Acquire theoretical and experiential knowledge, as well as intellectual skills related to the nursing process. You gain interpersonal skills, because if you can't get along with others, it's unlikely that you'll be able to think critically, because you're going to be out of the loop. People will not be, if you don't have interpersonal skills, people will not be including you, and so you will not have the data that you'll require for critical thinking. People will avoid you. There's always a balance, because the other thing to this, that, you know, if you don't get along with your peers and you can't do that critical thinking, if you're also perceived as being really too passive, too nice, and again, there's always, how can you be too nice? But anyways, that's what they're saying. If you're perceived as being too nice, that people often, they may think that, well, what does she know? And again, you're out of the loop. So it's that being very self-aware of how your presentation of self. If you don't have related technical skills, for example, IVs, nasogastric tube insertion, interpersonal skills that we've just talked about, even ability to work with technology. Nurses today need to be very techy. And some of our, you know, we have, 4 generations in the workplace, and they are not all techie. So we need to be techie and to be able to navigate through all these systems for critical thinking. So critical thinking, this is just a nice little model for all the elements that are important to critical thinking. So using that critical thinking model, move clockwise around the circle to identify points that reflect how you critically think. So just thinking about your communication ability. So, and I'm looking at the model. So those interpersonal skills, how does that relate to critical thinking for you personally? How do your attitudes and behaviors link to critical thinking? And we've talked about that being, you know, closed-minded, narrow-focused. Are you open? Are you looking at multiple perspectives? Well, tell me what you're thinking. No, I want to hear it. Tell me. So how are you really being open to all the multiple perspectives? Are you inviting them? It's hard to do. You know, sometimes I just want to get the job done. I don't care how you want to do it. I just want to get it done. Let's just do it my way today. We'll do it your way tomorrow. You know, let's just get it done. So, but really, tell me about why you think it would be better for the patient to do it that way, and I'll tell you why, my rationale. It's looking at the theoretical and experiential knowledge. Well, you know, I've been on this job for 10 years, and when I've done it this way, I've had this great outcome. When I've done it that way, the outcome wasn't the best. But whatever you'd like to do, let's come to a consensus here. So it might be that it's time to change. I might need to change my way as well, but it's being open to multiple perspectives and really having that technical ability. And we are required by the chasm that there's technological competencies that all nursing students have to accomplish. So it's really looking back at how well you're able to integrate the thinking piece with the actual technical skills. So using, okay, I think we've talked about clinical judgment. And clinical judgment, so again, problem solving at the very foundation, very basic, then you move up to critical thinking. Once you have your problem solving down, then you move up to critical thinking. And now we're a little bit higher and looking at clinical judgment. So it's knowing what to do, responding intuitively based on past experiences. It's knowing the patient as a person, knowing patterns, and I want to emphasize patterns. That's what we're looking for. If we're trying to establish patterns within the context of the work environment, the practices, and relationships among the team. And so really that clinical judgment is what we're striving for. If we have nurses that are practicing that have really good, strong clinical judgment, then we can mitigate a lot of our complications. A lot of the clinical judgment will occur as a result of analytic processes. So it's that developing those hypotheses, and again, that's a big, huge word I put up there with ontology, but it's developing the hypotheses that if I do this, then this will occur. So our hypotheses many years ago, and I've shared this with you, our hypothesis many years ago was that if we put brown soap, the Sunlight soap, it's a bar of yellow soap, and we used that soap and we rubbed it over bed sores or pressure ulcers on the coccyx and dried them up, really dried them up, that they would heal faster. Now we know that's not the truth. We know that moist healing is the only way to go. And not only did we use soap, and we rub it all, we moisten the bar of soap, rub it over. I'm just hoping we didn't share that bar of soap from that coccyx to the person beside them's coccyx. I can't guarantee. And so, and then we put oxygen in a styrofoam cup and then blow the soap to dry it. It was good and dry. It was rock solid dry. All that eschar was just festering underneath. So it's that analytic process where you develop the hypotheses, and through deductive reasoning, when nobody healed, we knew that didn't work. It is also, they talk about this intuition, so that immediate understanding of the situation. And I'm going to suggest that an intuition is really your experience and you acknowledging on a, and this isn't in the book, but it's on an unconscious level, that you're recognizing patterns. And the example I think I've used with you folks is, you know, when you've got your 2-year-old who can't really articulate, they're not feeling well, you feel them, they're a bit warm, their cheeks are flushed, but they're also cutting teeth, and they're not themselves. They're not eating, they're a little bit whiny. You think, oh, they're coming down with something. So you keep taking their temperature to see when they spike their temperature. And so it's recognizing those patterns. And so you could say, yeah, I'm very intuitive. This patient, that my child is going to develop. But in fact, you're recognizing those patterns. It's narrative thinking. So we talked about that larger systems thinking, that paradigm, whereas it's that narrative thinking, really doing that in-depth story, because all of our patients have a story. And then reflecting. It's that really in-depth reflection where you're going to learn from your experiences so that you can do something differently going forward. Or, and that's what we always say, that you change the situation. And usually when you reflect, it's something that's disturbed you, that little niggle in your belly. But I'm going to suggest that is there some opportunity that you can also acknowledge when you've done something really good. So reflect on positive experiences as well. Although human nature, we don't do that. And so, clinical judgment, and this is something that's not new to you, is this model of clinical judgment, which is based on Tanner's work. And as you will see, it's noticing, interpreting, responding, and reflecting. What did we say that was sort of a mirror of? The nursing process. So Tanner's taken the nursing process and just changed some of the language. So noticing is sort of developing that grasp of the situation. Then moving forward, through analysis, through intuition, sort of looking at what if I actually assess and interpreting the situation. So through my assessment, this patient has chest pain. I don't see any, I know there's no fractured ribs, there's no sputum, there's no fever. So, and there is some ECG changes. So I think it is probably myocardial. And then deciding on a course of action to take. Well, this is a myocardial, so we need to get him into the we need ECG and into the cath lab quickly. And so really deciding on the course of action, and then attend to the responses, so that a reflection on action. So as you are in the moment of hooking the patient up for the ECG and you're thinking, oh my gosh, which is it? Red, yellow, green, blue, girl, which is, next time I'm going to bring my poster so I can see exactly how to hook up the ECG. So attending to those responses and then reviewing the outcome. Did I get the patient, did I meet all my timelines, my benchmarks? And we've got benchmarks such as the QBPs. Everybody familiar with the quality-based practices? I understand now they've got, so I was familiar with the congestive heart failure, COPD, and now they've got one for breast surgery as well. Are you familiar with that one? No, I just noticed it last night when I was doing some. So they've got these quality-based initiatives. We also have the Safer Healthcare Now patient safety benchmark. So for someone coming into the emergency department, they need to get the ECG down within 10 minutes. They need to have the door to needle time within 30, and that's benchmarked across the country. And the hospital reports on that, and people see that. So if that hospital takes 45 minutes to get an ECG done, I'm not going there. And so it impacts their funding. So it's really looking at those benchmarks and making sure. And so next time I'm going to get that ECG done within 10 minutes, I'm going to be right there. That's why a lot of hospitals now have 2 triage nurses, and they also have the ECG machine right there. So as soon as you say chest pain, it's on and the ECG is done. Because they're benchmarked, and that's their fund. It affects their funding. Critical thinking in the nursing process. I think we've already talked about that. That really the nursing process was really an earlier model, and my thoughts on that. I thought it was very much a linear process, and I was really not too much into the nursing process. Although now you know that you have to have the nursing process for the NCLEX, so we have to put this back in. And I think that really is just a problem-solving strategy. And I've shared with the group that when I was first in school, that's how I was taught with the nursing process, was that, okay, now you've got a flat tire, now you go out and you assess it. Yes, in fact, it's a flat tire. And so what are you going to do? You're going to call someone to do it, or you can do it yourself, and make a plan of action. And then after, can I drive the car? That's my evaluation. That was how nursing theory was taught to me. And so the nursing process is still very relevant, and it's what we do every single day in our everyday lives. And so just remember that we do want to remember the API, assessment, planning, intervention, evaluation. We tend not to do the nursing diagnosis here in Canada. That nursing diagnosis really didn't take hold in RN practice. I don't know about in RPM practice. I know that they were taught a lot, and I'm thinking, why? Do you ever report to a physician, I have a patient who has ineffective airway clearance? If you talk to a physiotherapist, I have a patient I'd like you to see ineffective airway clearance. No, nobody knows what you're talking about. So I don't know why the US very much promotes it, but we don't. We tell it like it is. So again, just remember when we're doing our assessment, you want to identify the client strengths as you're doing your assessment, health status, any kind of risks and concerns. And that analysis piece, so that might be where we have the diagnosis, but this is where I guess during the planning is when you're actually analyzing, and that's where you fit in your diagnosis if you had to. And so you would be looking at the client data, you'd be looking at your own assessment, and that's sort of where that would sit. And as you know, I always thought that the nursing process was linear, but my colleague has actually assured me that it is iterative, which it is. So as you go through the whole process, you evaluate. Again, I can't emphasize evaluation so strongly. Evaluate, and when you evaluate, then you start the whole thing all again. So you evaluate, this worked, I'm going to do it again, I'm going to evaluate, or this didn't work, and I'm going to do it again and reevaluate. So critical thinking throughout the nursing process. I think we've already talked about this, where you're getting relevant data, and again, you have to show a high level of discernment. You want to validate or triangulate any of your data. So patients complaining of chest pain, you want to maybe do a chest x-ray and an ECG just to confirm that there is no fractured ribs, that sort of thing. During the analysis phase of the planning, you're going to establish patterns. You're starting to look for those relationships between was having chest pain, and I do see ECG changes, and making inferences. Well, this might be myocardial ischemia. Then implementing and documenting the care that you're providing, but again, always evaluating. I think we've already discussed this, slide number 37. Okay, so we're just going to briefly talk about the authority, so delegation and the authority mechanism. And so when you are delegating, and that goes for RN or RPM practices, the nurse ensures that they have the appropriate authority before they perform a procedure, and they know their scope of practice. So for instance, application of energy is not part of RN practice. We know that's part of the nurse practitioner role. However, when someone's heart starts to quiver or fibrillate, one of the interventions is quick defibrillation. And I worked in a cardiac cath lab where it happened a lot. So I needed to have the ability to provide defibrillation. And so all of the physicians, all of the interventionists at Sunnybrook signed a statement to say that I would be able to, that I had the knowledge, skill, and judgment to perform defibrillation. And in my role as educator, then I could teach the other nurses about it. I couldn't tell those nurses that they could do it, so I couldn't sign everybody off. I signed them off to say they were competent to do what they did, and then the doctors would, the interventionalists would all sign them off, because only the interventionalists or nurse practitioners could do the application of energy. I don't have that authority. So you need to have the authority within your scope of practice to delegate. So now that we have those four acts to nursing, those are the only things that we could delegate to the appropriate body. So delegation is the formal process that transfers the authority to perform a controlled act. And remember, we've got, what, 21 controlled acts, and out of those 21, nursing does 4. We could get a directive. So in the event that a patient is pulseless and apneic and unresponsive, and on the monitor there is a very quivering waveform, then the nurse is able to defibrillate. That would be like the directive. So give the only instances. So contraindications to this, and I'd have to lay it out. So the patient had a pulse, well, of course. But you have to lay out these very specifically when this directive could be enacted. And so the initiation is the authority to initiate specific controlled acts. So when we're delegating acts, and so defibrillation is an example, nurses need to have the competence in both cognitive and technical aspects of the job. So if I'm delegating defibrillation, I'm not delegating. If I am, if the physician group is delegating defibrillation to the nurses, and I'm just the person that's making sure that everybody has competency, then I need to make sure that they have both cognitive ability, so they know when to recognize the ventricular fibrillation, but they also can manage the paddles in a safe manner, or the pads, or however we're using the equipment in a safe manner. So you have to be, they're very strict about that. So you have to make sure that someone has that cognitive and technical ability before they perform it. And not only that they have the ability, but the College of Nurses also says that they also can manage any undesirable outcomes. So if there was something that happened, what would the person that you were authorizing to do, would they be able to manage it? So I think nurses can manage. The patient's dead now anyway, so they can't be, deader than dead, but they would be able to manage any untoward outcomes. So if the defibrillator, one time it sparked when I was actually doing my shocking, it actually, a flame went across the chest. Could I manage that? Because that was a complication of of defibrillation, yeah, I could manage it. I do admit it made me very unnerved and very scared, but I could manage it at the time. Nurses need to be able to manage the outcomes, and they have to have the competence to manage the outcomes. And if not, then decline. And so just a quick case study here. Mr. Siddiqui was admitted to your postoperative floor complaining of pain. You notice he's pale, diaphoretic, and vomits. His pain rating was 10 out of 10 on a numerical rating score. He has a PCA pump attached for pain management, and he's at his maximum dose. So what would you think is the critical thing? What critical thinking is required for this particular case? Identify the assessments that you would make to determine a plan of action, and how would you evaluate it? So just in your, pause the presentation and you can work through the case study. And so for me, I would say, well, first of all, we start with it right at the beginning. The assessment. We need to determine what is actually going on here. So we're going to do our pain assessment. Now, as you know, that someone's reported that the pain is 10 out of 10. As a practitioner, I'm going to quickly do my own assessment. We always do our own assessment. Yes, we may take somebody else's word for it. I want to put my own eyes, because if I'm going to make an intervention based on those assessments, I need to put my own eyes on it. So I'm going to put my own eyes on it, do a pain assessment, both a subjective and objective pain assessment, and then I'm going to plan the improved pain management. So with the patient, I'm going to actually find out what would he like to see with his pain. Maybe he's okay with his pain at 3. I mean, if it's me, I'd want it at 0. So you want to have improved pain management to heal, to sleep, to eat. The intervention. And I'm sure you're thinking this already, that the intervention would be discussed with the team. Mr. Smith or Mr. Siddiqui is having increased pain. He's maxed out on his PCA. And I would use that S-bar. So he's not moving, he's not deep breathing, coughing. And so could we increase his analgesic? So you might want to get an increase in the analgesic because he's maxed out now, but maybe there is some room to go up. Or maybe he needs to have a different type of analgesia altogether. And you might even want to add in a non-pharmacological method of pain relief. And then once I'm finished, I want to evaluate. I'm going to reevaluate my pain score. How's your pain now? Should we go for a walk? How about having something to drink? So always doing that evaluation. So from the College of Nurses, this is from the professional standards. The entry to practice competencies. And I just want to tell you that there are 100 entry to practice competencies, and over the course of the 3 years that you're with us, that you should be able to accomplish all of those, but you don't have to do them in any one rotation. So the entry to practice registered nurses apply knowledge and use critical inquiry, because remember, problem solving, critical thinking, critical inquiry. That's what the CNO is asking of RN practice. Critical inquiry to support professional judgment and reasoned decision-making to develop healthcare plans. Their proficiency and productivity related to workload management and technical skills will increase with support and experience. They report and document client care and its ongoing evaluation in a clear and concise manner. So very clear what the expectation of a grad is from CNO. And so as you're pondering that thought, you're thinking, well, how does that really differ from RPN practice? I want you to think about that for a minute. How does that really change? And again, you're thinking that you're including data that you've been an RPN for many years, you've worked in many different environments, you've taken a lot of courses, but at the same time, as you graduate as an entry-level RN, how does that compare in terms of knowledge, skill, and ability? So I just put that out there. Critical thinking potential. When you are examining your critical thinking, have I examined how my values and beliefs affect my thinking? And that's all part of that reflective process with Christopher Johns. How confident am I in my ability to reason? How secure am I asking for clarification? And as a new grad, you remember that you didn't want to ask anything, questions of that particular person because they might think that you didn't know your job. But now as an experienced practitioner, I have no problem saying, I'm just having a brain freeze. Can you just tell me, come and have a look at this? I'm missing something here. I have no problem saying that. We all have days like that. And we want to, as part of a patient safety initiative, we want to have the back of our colleagues. So, maybe they're distracted, they have a sick child at home, they come to work anyways. And so we have each other's back. And so did you miss this? Did you see that? I just wanted to let you know, I'm noticed that the lab results came back, they're all flagged. Do you want to, did you see them? So always helping one another. How am I open to new ideas and viewpoints that differ from my own? And I think it's really getting into that practice of critical thinking, that habitual, deliberate, mindful practice. How do you communicate with your colleagues? Remember that that's a really important point. That is, people that are open to dialogue and communication, they're in the loop, people keep them well informed. But those of you people that we work with that are a little bit more maybe harsh, we don't communicate as effectively. Now again, there's different styles of communication, and so maybe it's just not, their style doesn't appeal to me. I might avoid them, and I'm missing key pieces of information. Do I anticipate and solve problems effectively? Do I find answers and solutions? I'm going to say we need to be relentless at that because it's all for patient outcomes. I remember one time that in our CVICU, we had some patients that should have been repatriated back to their original hospital. And so our secretary had called 9 o'clock, no beds. Well, of course, any hospital's going to say there's no beds. Really? They're going to say, oh yeah, we'll have the front door open. We'll be waiting at noon. I knew that. So I called myself later, and of course, no. And then I called every 2 hours until finally at 4 o'clock in the afternoon, I got someone who says, yeah, we have a bed. I'm like, yes. Because if beds were blocked at our place, we couldn't do open heart surgery, which meant we couldn't decant from the community. So it was one big vicious circle. So if I could get that patient back into that bed, then we could open up a bed and bring a patient in. So I was able to get a bed in the fellow in the unit at the time said, if you can get this patient out by tomorrow morning, I'm going to bring you a latte. Well, I won the latte because I was relentless. I was persistent. Another one of my colleagues, it was actually, this is all confidential, right? There was a colleague who, we were in the prep and hold area at the cath lab that day. We were working. BJ was my charge, and she had a patient, elderly lady, who had fallen and broken her hip. And so that she needed a total hip replacement done, and otherwise she was bedridden. And so they cathed her. Yeah, you need to have a stent placed, and you can't have a stent. You have to have a stent first, and you have to have surgery. We are going to be booking stents for about another 6 weeks, so you need to go on anticoagulants, I think Coumadin. And all Coumadin, that's like, it takes forever to reverse it. So you can just see this is getting farther and farther. She's 80 some odd years old, so being bedridden would be her demise. So my colleague BJ stood at that desk, and anybody that walked by that desk said, can we do that procedure? Can we do that procedure? We need to do that procedure. Can we stent that patient? Let anybody interested in staying a bit late, can we stent that? She did not let it go. And she rallied the troops. And so we said to one of the interventionists, do you think we could just get this case done? If we could get that case done, the patient could go home that day, surgery could be in a week, and the patient would be enjoying a better quality of life. And so that was how we need to be persistent. We need to be relentless and persist. And that's not just in verbal. We have to be able to have effective interpretation, learning and interpretation. We have to be able to absorb knowledge and understand it, but we also have to be able to articulate it in a cohesive manner. And we've talked about the importance of communication and connecting with people. That's really key. And so really, I don't think I need to talk to this group about empathy. I think that we just have to let people know that to practice empathetically. Avoid making assumptions, although I think we did make some different inferences, which is a little different than assumptions. But again, I think you know what I'm speaking about, that we just don't assume that this is what it is until we really examine it from multiple perspectives. Okay, I think we'll skip that activity and go to any questions. Okay, I'm going to ask, are there any questions? People online? Any questions? Any questions for the room here? And so I know we flipped through that fairly quickly. I just want to remind you that this is available to you. I will make the recording available to you, and you can go through it and stop it and start it as often as you want. But do remember, it's like when I watch Netflix. It's a 45-minute video or program, and it's cut out all the commercials, which I love, but then I play that same thing over and over because I missed what they said. So don't do that. Get the essence of the discussion and then move on. Don't worry about getting every word down detailed. Okay, so why don't you I'm going to say pause the video and you can take a break, but for the people in the room here, I'm going to forge ahead so that we can get everything in, but if you need to get a drink or you visit the washroom, please feel free. And I'm just going to set up for the next one here. Nursing education will be what we're going to discuss now, is nursing education. Bear with me while I try and get my next PowerPoint up. I think I just have way too many windows open. That's probably the... Okay, everyone, I think that this is the... Let me put the right one here. Okay, so this is from our week 12, and this portion of the presentation will be on nursing education, advanced practice, and leadership. And so we sort of have gone through every single week contributes and culminates in this sort of last final presentation. So if it seems a little bit out of the order, that's the reason why. So we'll talk a little bit about nursing education and advanced practice. The learning objectives for this session are to understand the importance of standards in nursing education, to understand the process of accreditation by CASN, or Canadian Association of Schools of Nursing, to appreciate the development, growth, and importance of graduate education in nursing, both master's and doctoral education, to describe the clinical roles and activities of advanced practice nurses and clinical nurse specialists, to understand the entry to practice competencies that foster lifelong learning in the registered nurse profession. And so, as you are all very aware that the minimum entry to practice now is a baccalaureate degree, or BSN. So that's the minimum educational requirement for nursing. That came about, it was a very slow process, and that, as I mentioned, was highly controversial and very heatedly debated in the past. And so now they thought that with the work of nursing and how nursing is changing, and other professions required a degree, and so they felt that a degree would be really the minimum. And so I see now where physiotherapy is really going to a master's degree for entry to practice because of the work that they're doing. And so I don't know where we'll end up, but certainly since 2005, baccalaureate education has been the minimum entry to practice. And at the same time, just to give you a little bit of history, and I know this is not new information, but prior to 2005, Durham College had a very robust nursing program, and as did other colleges, had a very healthy, well-subscribed nursing programs. 2.5, 3-year programs. They're very, very successful in writing their entry to practice exams. And so once that the mandate of entry to practice became baccalaureate, then the government asked if we would all collaborate. And so because Durham College and UIT are on the same campus, but prior to UIT, Durham College collaborated with York, and so the universities and the colleges collaborated. The beauty of our collaboration is that we are on the same campus, and so we also have some other philosophical changes or philosophical differences in that we believe that the faculty should become totally integrated, so you wouldn't be able to tell who is Durham College, who is UIT, other than that your class would not have been going or running if you were in being taught by Durham College faculty. But otherwise, it's very seamless. As I mentioned, students don't do the collaboration. It's really only the faculty that do the collaboration. I shouldn't say students, we all collaborate, but we are the ones that actually physically do the changes. So I teach in both second year and fourth year of the program, and my tenured faculty colleagues teach in year 1 and year 3. So we teach to our strengths, and we have a totally integrated program, which is quite unique in the province. And so, position and development. So the entry to practice are often misunderstood to mean that all nurses require baccalaureate degree to maintain their practice. Well, we know that there's many nurses that did not opt to take the baccalaureate. So in 2005, there was many nurses that, and I don't recall the numbers, but I would suspect there must have been 40 or 50,000, if not more, RNs that were grandfathered into this clause. And so that meant that while there was a new standard that the entry to practice would be baccalaureate education, they would be recognized for their expertise. And I would say a good majority of them have gone back and obtained their RN to BSN. That's been, in fact, our program, we had that program for a number of years. We've sunset that because there wasn't the need. The only people that do that right about now, I think, are Ryerson. They've been running it for the last 12, 15 years. And I think that will soon be sunsetted as well. So why BSN preparation? Why was it so important that we have a baccalaureate education? And so as nursing practice was changing, as our clients and patients were becoming much more complex, much sicker, and the knowledge that was required for RN practice was becoming much more comprehensive. And so that's why there was more integration of science. Now, I have to say, for my program, to 1976, we did have a fairly heavy component of science, and I can tell you every little detail about the gallbladder. If you ask me about those sphincters and all of the bile, I can tell you that because I memorized that so well. But other things about caring for a patient with a GI bleed, totally missed that. That was not part of it. It was not care of the patient with, but more the science, the hardcore science. So now we know that we need to have a combination of that hardcore science coupled with nursing practice. So nursing practice is also becoming so specialized. There's over 30 different clinical areas to specialize in, and you probably have been to the CNA website where you can actually write, I think it's now 21 different designations or certifications, from mental health, critical care, pediatrics, gerontology. There are so many certifications. So advances in health sciences have meant that nursing education must now go beyond the basic level. It must encompass the baccalaureate to ensure safe and effective practice. You need to have that educational background. And for myself, being a 2-year program, I did have a good, strong science. I didn't have the nursing piece of it, which they quickly discovered was a gap. And so, but with experience, we were able to learn that and integrate that into our practice. But in the meantime, I also went back to school for many different certifications, an oncology certificate, then a critical care certificate. So I was constantly upgrading, and that's where we would have developed that knowledge. Standards of nursing education. Historically, nursing standards have been a primary concern of nursing, and first-degree programs were non-integrated programs. So they would be, and when I was in school, going back for a baccalaureate, university was not even, I knew of university-educated nurses. I knew of, they were always VON nurses. I didn't know anybody else that had a university degree. When I was in practice for about 10 years, one of the managers went back and got their BSCM, but it was not common language. I did not know of anyone who had a baccalaureate. Hospitals had control over the clinical aspect of nursing education. So that's how, just prior to the year that I graduated, or the year I entered the program, the hospitals would take all of the nursing staff, and you would actually go and do AM care for all the patients, tidy up the units, and then you would sit in class all afternoon and you learn how to do a dressing. Then the next day you do all the AM care and the dressing. And you sort of learned it the morning before, and you go and apply it. And there wasn't always the clinical supervision either. So it was really, the hospitals did all the clinical, and now the university is responsible for all the education, both clinical and theory. Standards of nursing programs. So programs are all accredited. So every nursing program, and of course in our province of Ontario, we have 13 universities and about 24 college partners, and they're all accredited through CASID. And there's these standards that we have to adhere to, and we have to provide evidence that we're teaching. And so once they go through all these big binders that we create of all student work and how we exemplify our mission and vision. And so if you were ever asked a question about what sort of curriculum does UIT, Durham College, aspire, it's the caring curriculum. It's based on Bevis and Watson's caring curriculum. And so when that means that we as faculty have to model that caring to our students. So if you find that one of us is not demonstrating caring, then you can address us for sure. That's all part of it. The same as if I thought that someone was not being caring to their patient, the CNO wants me to address that as well. So it's the same sort of thing. But you're from the caring curriculum, the Bevis-Watson curriculum. And so this whole approval process, oh my gosh, it's so, and I'm sure that many of you have gone to through accreditation at your hospitals. So on a regular basis, they'll invite 3 accreditors who are experienced, they know how to do that. They come and meet all the faculty, so they come on site, they're here for a week. In advance of that, and it probably takes a good year, we start having meetings and creating the binders. I'm hoping we can do it electronically. So we have these binders of very excellent work, and for what? So they'll ask us questions. First of all, how do we live out our mission? How do we demonstrate caring? All of these sorts of questions. How do we integrate new, so let's say technology. How do we demonstrate technology in our program? So we have to go through every single course and demonstrate how we've integrated technology. Or how have we, the biggest thing right now is the indigenizing the curriculum, or being cognizant of our Indigenous heritage because of the Truth and Reconciliation Truth and Reconciliation document, but trial, whatever it is. And so because of that Truth and Reconciliation piece, we are now we are now integrating Indigenous studies throughout our curriculum. So when COSN comes to accredit us, they're going to look to see how we've done that. And they'll think, well, that's a really good idea, or gee, that's not how we would do it. One of the big things that I found that was some of the programs that was a gap, because we sort of had this pendulum shifted, it was all theory, and we missed the boat on some of the the important stuff. So apparently there was at Sick Kids, there was a child, that young girl with sickle cell, who went into shock and died, and the new nurse missed that. And so they wanted that when they went to inquest, all young children or maternal deaths go to inquest, then they asked her, where did you learn about shock in your program? And she said, we didn't. Not this program. I won't tell you which program. And so that from that point forward, we had to demonstrate, where do we teach shock? Show me what you teach, not just a superficial type, because it's so serious. So now I take it to the extreme where I have everybody sign in for that lecture, so that if it does go to court, I can say didn't go to class that day, or we talked about all of this for 2.5 hours. So because of these pieces, it can be litigated. So that approval protects the public by ensuring that the students are prepared to meet the demands of a current healthcare climate. We also have the CNO involved there. The CNO provides the regulatory requirements, but also will provide the entry to practice. Like they get you all organized for the NCLEX, and the CNA the Canadian Nurse Association used to administer the entry to practice exam, and they no longer do that in favor of the NCLEX. So it's a multi-tiered system of approvals and legislation. But it is CASN, Canadian Association of Schools of Nursing, who actually do the come to on-site. They're here for a week. They go through every binder. As I said, they speak to the students. They'll speak to every year level. They'll speak to different classes. They'll speak to the bridgers. They'll speak to the bridgers here, the bridgers up in Barrie. They'll speak to the faculty. They'll speak to the coordinators. They speak to our stakeholders. So it's a quite exhaustive process. And then they take that all back and file a report that yes, you have met and you're doing an absolutely awesome job, or they'll say you're doing a good job, we'd like to see a report in 2 years, or you know what, you've got some serious problems. And there are programs right now that are not accredited, and so always be mindful of when you go for your next degree, and I assure you that everyone in this room, I'm sure, will entertain that, and so do know that making sure that you look at their accreditations. Now, I do want to tell you, we got a 7-year accreditation, which is the maximum. So you can take a deep breath and know that you've got quality education. What else do I want to mention here? So the accreditation really is, there's the stamp of approval that states that the evaluation of how we meet these standards that CASN prepares for education of nursing students. And so one of them is around how do I teach patient safety? And so I embed it in multiple ways, because I believe that you're not going to learn something. It's not just a one-time deal. It's being constantly exposed to important concepts. So evaluation of educational programs in relation to the standards. Graduates are prepared to meet the requirements determined by the regulatory association. So if our students, so as you know, on the CNO website, you see all the pass rates. And so as we move to the NCLEX, our pass rate was not where I like to see it. And so, but again, it was an unknown. All of a sudden, we were writing the Canadian Registered Nursing Entry to Practice exam. 3 months later, we started with the NCLEX. So we knew it was coming, but we had no idea what it was going to look like. We were told that it would be the system, but our content. No, we were mistaken. It is American content. And so the best we can do is educate our students to know, and I think they're now putting on Canadian American lab values, but really to understand some of the nuances that you might be exposed to. Most part, it's the same, but the first exam, they had to learn Obamacare, just so that they could be competitive. They also, the NCLEX, because of the way it's written now, so we used to write one cohort in June, and the next one would be in, I think, in January. So we would have, so we knew that how many people wrote in June, and I would say mostly it would be 99% of our students would write at one writing, and then maybe somebody would wait a bit for whatever reason. But now people write it all over the place. So they might write it as soon as they graduate, they might write it 2 months later, 6 months later. I had one person write it 18 months later. Oh my gosh, my heart sunk. But again, so it's hard to compare those stats if you're not comparing apples to apples. People are writing all over. Plus the fact they haven't separated out our some people write once and they may not be successful for whatever reason, and they write it again and they're successful. Well, that goes into that other pass rate, so it doesn't really, you're not looking at the right numbers. But nonetheless, that's the way it is. And so, and now the CNO is looking at, if you do not maintain a certain pass rate for the NCLEX, then your program won't be allowed to operate. So that's going to be a challenge, because we don't teach to an exam. We teach to the standards, and we teach to what your work environment is going to be. You're not going to be caring for anybody who's got Obamacare. So, you know, so we take that all into consideration. So the Canadian Association of Schools of Nursing approves and accredits university programs, and we are all accredited, we know that. I think this will be a familiar model for you folks, the entry to practice framework. That's from the CNO. And if you look at all the pieces, as you'll see in the center core, as always, it's the patient or the community, the nurse, and the interprofessional healthcare team. That's sort of the core, but really the core is the patient, and around all of that is the nursing process, the assessing, the planning, the implementation, and evaluation. And I want to say that the client can be your acute care patient, community patient, or it can be a community as patient. As you'll see, those 4 arrows: self-regulation, service to public, professional responsibility, accountability, ethical practice. Those are all influenced by knowledge, or influences knowledge and knowledge application. And so those are all the pieces of our evaluations currently. So when you go to clinical, our evaluation is based on that. So it makes it nice and easy for you to be evaluated. Again, this is just another sort of view of that entry to practice framework. And these are all just elements of what I just mentioned. Of what does ethical behavior look like, or ethical practice look like? I don't know how to get rid of all those faces. So ethical practice demonstrates competence in professional judgments and practice decisions by applying the principles implied in the code of ethics or ethical framework. So again, there's ethical frameworks, and I know that I've just pulled one off from Markham Stouffville. Does anyone else have an ethical framework at your place of work? I was really quite delighted to see this. Let me see if I can. Oh, so at Markham Stouffville, they have posters up for everybody so that everybody's working from the same ethical platform. An ethical decision-making framework, which includes, you determine the question. So what is the ethical dilemma that's occurring here? You need to gather the relevant data, and we've talked about the multiple sources where you can collect the data from. Identify the conflicts as well as what's congruent. So what do we agree on, or what is agreeing here, and what is inconsistent with what my values are. Brainstorm options, weigh and balance options. So now you've got 10 options, but not all of them are going to work in this situation. So let's just take our top 3. Then you're going to look to ethical theory, ethical concepts, and ethical principles. And so those ethical principles of maleficence, non-maleficence, beneficence, justice, and veracity, and looking at all of those, and then helping you to base your decision. So is this decision best for everybody? Is it best for this one individual? Should we sink all of our resources into one person? An example came up over the weekend about a liver transplant. Should someone who has been liver failure, a young 40-year-old requires a liver transplant for liver failure as a result of alcohol abuse. And so this patient has been 3 months alcohol abuse free. The guideline says you have to be 6 months. But it's unlikely she's going to make it to 6 months. They need to do it now or not do it. So what do? So again, you're going to collect the data. I want to see the policy. I want to look at listen to all the stakeholders. Look at the patient situation. Maybe we can keep the rules say 6 months. So where do we bend the rules? And the thought was, well, you know what? We have patients that are never drank and they're on liver failure. Should they not get the liver? Are we being judgmental by saying, well, you know what? You abused your alcohol, you abused your body, you did it to yourself. So again, being non-judgmental in our approach. What is the right solution? The family just said that, you know what, can she not just have a piece of my liver? Because those types, you can do partial liver transplant. Can I just not give part of my liver to my sister? So again, this partial liver could be given to somebody else who's been on the transplant list longer, who may have not used alcohol. So there's all these dilemmas that need to be considered for these sorts of situations. This is a patient who's denied in Ottawa. So no, our rule is hard and fast 6 months. No, nothing less than 6 months. So she came to Toronto, and the UHN said, you know what? Let's just look at it. Let's look at the individual holistically. Let's see if we can't come to a compromise. So again, I just put that out there that we have to be always thinking about the ethical practice. When you are in practice, you need to have competent application of knowledge. And so when you're actually doing nursing clinical next May, June, July, or after that, in 4700, you need to demonstrate competent application of knowledge. And so it's not just skills, that's all part of it, that you need to be able to do your skills as well, but you need to be able to demonstrate application of knowledge and higher level thinking. Professional responsibility and accountability. So again, professional comportment at all times, that's really important. And I think one of the key lessons that one of my collaborative students learned was the professional stance. So she realized that she couldn't be sitting on the floor. There was a little space, she was very tiny, but there's a little space between the monitor and the wall, and she would just snuggle right up in there. And I thought, that is not what we do. Nurses do not sort of squish into a corner. So let's always remember the professional stance, self-regulation, so being accountable for our own actions, owning up to when we've made an error, and mitigating the response, mitigating any problems from that error, as well as reflection, and then service to the public. Nurses are always very altruistic. They're always the ones to volunteer, but also that we need to protect the public, but also we need to improve health services. Be always looking for improving health services. So as a result of the need, as everything was bumped up, so entry to practice was now baccalaureate, it just bumped everything up. And so there's development of graduate programs preparing nurses for roles in leadership, supervision, administration, and consultation. I thought, well, where's education there? But I guess you could put that in leadership or supervision, but definitely for education. The first master's program was out of UWO, University of Western Ontario, and that was in 1965. And there was 37 students. The first, as we know, the first doctoral program was in Alberta in the early 90s as well. So again, it just stuns me that in my lifetime, there was no PhD program here in Canada. All of the profs went to the States to get their doctoral education and then come back. And I would suspect many of them did not even come back. Overview. Master's program. I think the headings are being cut off this, but oh well. So masters and nurse practitioner masters, their programs can be either thesis-based or it can be research-based, course-based, and then there's one that has a nurse practitioner focus. Nurse practitioner programs now have to be graduate. They have to have a master's to go into a nurse practitioner arm. There was a time, and perhaps I think it's sunset, maybe it's still in operation, but Ryerson offered a BSCN to nurse practitioner stream, and so you just had to have a BSCN to be a nurse practitioner. But again, it didn't prepare you for all of the pieces of the role that you needed to know. So as you were moving up to the outpost up north, and you're working independently and that sort of thing, it prepared you for skills. Like you could suture up really well, that sort of thing. But as you know, it's so much more than skills. Doctoral programs prepare scholars and scientists, nurse scientists who will develop knowledge for nursing. Knowledge can be integrated into practice and policy, and so it's basically varying levels of coursework. So you might have 6 or 9 courses, and then after that you would it's thesis based, and you would be doing your research. It's supervised, and so you have an expert in that area that will guide you, so that you'll have your own area of expertise. As I mentioned, the first program, a doctoral program, is actually the late 80s in Alberta, and there was 2 doctoral students in that program. Oh my gosh, I couldn't imagine that. Those doctoral seminars must have been pretty long. And then currently there's I forget how many doctoral programs. There's many doctoral programs now, but not all of them are as robust. And in fact, I did for my doc seminar, I did a quick scan of all the different programs, and there was actually one that was closed for 2 years because they weren't graduating enough PhD students. So because our education is heavily funded by the government, as you know, although we think we pay a lot of tuition, that's probably about half of what you would pay in the States if we were paying for the true loan. But our taxes defray some of that. That's why in being full-time is so much more lucrative. They do a count here in November to see how many students we have, and that's how we get based on, that's how we are funded. So our education is really heavily subsidized. And so with all these PhD programs, if they're typically a PhD program would be 4 years, although I had one colleague complete hers in 2. I don't know how she did that. She mustn't have done anything, even sleep, because I don't know how you could do that. But typically they're over 4 years. And the first 2 years are coursework where you get your research piece under all the theory, and then you go off on your own and do your research, and then you write it up and report it. But I think there is a special, and I'm just throwing it, I think there is a special niche or a special few that can mentor doctoral students. I think that at that level you need to have somebody that's very experienced and knows how to guide and tutor students, coach students. And I know with my supervisor, I'm absolutely not. I've learned more about teaching than I have. I mean, I've learned as much about my doctoral studies, but more about teaching and being an expert teacher, because she is so excellent in what she does. So that's where I've learned a lot. And they also go into postdoc work as well, postdoctoral studies. So you do your research, and then because now you're going to start to be recognized for your area of expertise, people will approach you, you know what, come and work with me, I have some grant money, and we can really develop some knowledge in a certain area and really expand on your work already. The history of advanced practice. So advanced practice, as you are coming to find out, is that it's really a catch-all title. And so it's someone who's prepared at the graduate level. It's really emerged over the past decade, and it was a new goal. So up until probably the mid-2000s, we didn't have really advanced practice nurses. Or maybe we were very progressive at Sunnybrook, and Dr. Mitchell actually saw the value of having advanced practice, and so she actually instituted, but the hospital kept thinking that, oh, well, we're going to have a budget cut and they'll be gone. And they actually did not go away. So we had these advanced practice nurses that were really very instrumental in helping deliver patient care. They actually didn't do the care, but they'd help nurses deliver care. They were good for developing policy and some of those broader topics. Then in the 1970s, there was clinical nurse specialist. Now, we always had a clinical nurse specialist, and I could never figure out how did she get to be a clinical nurse specialist other than expertise. So Luann Van Riesch at Sunnybrook, who was the wound and skin care nurse, I don't think she had a master's till recently. When she first did her work as a clinical nurse specialist, she was baccalaureate prepared, and she just became such a specialist in her area and was just recognized for that, as opposed to being a title or some kind of accreditation that she had accomplished. It was just being an expert in her area. So as you know, that the advanced practice nurses, it's an umbrella term describing an advanced level of clinical nursing that maximizes the use of in-depth knowledge, graduate preparation, and expertise to meet the healthcare needs of specific populations. So in my graduate, my master's was course-based, but we did courses that were also relevant to education. My stream was at Ryerson, so I was in the leadership and education stream. And everything was all linked to either being a patient care manager or being an educator. The process is for being an advanced practice role is that really high-level analysis, interpreting, and application of theory and research to advance nursing knowledge. They're instrumental in that knowledge, that KTI to practice, so that knowledge translation into practice. The advanced practice role is so key to that. So once they started hiring these advanced practice nurses, then they found that there was decreased hospital admissions and emergency visits. They had a shorter length of stay, a decrease in UTIs and skin breakdown. There was better symptom control. The patients were not complaining of shortness of breath or of pain. What do we call those types of rates? And when we're reporting on the urinary tract infection, skin breakdown, pain management, lessening of nausea. Those are nursing sensitive indicators. We talked about those earlier in the course. Nursing sensitive indicators where we have direct control over, turning our patients. And in some hospitals, they actually have a bell that goes every 2 hours to make sure you've turned your patient on time. Promotes evidence-informed care, and it actually gets the evidence to the bedside, and increases the capacity of patients to improve personal health. So at Sunnybrook, because they had these different roles, so they had the advanced practice role and the clinical nurse specialist, they would have their roles broken down. And so for instance, it would be 20% education for nurses on the floor, on the unit. It would be 60% patient related, and then 20% would be leadership. Whereas clinical nurse specialists, they would have 40% or maybe 50% patient responsibility, 30% organizational activity, and then maybe just 10% nursing education. So these roles were really well defined and broken down, so everybody knew what their job was. So the competencies for advanced practice, they had to have clinical competencies. They needed to have advanced assessment abilities. They need to be able to analyze complex patient situations, engage clients and team members. They need to step back and take that 20,000-foot view, looking at the trends and patterns that were emerging. So maybe there was a lot of urinary tract infections. Maybe there's a lot of bed sores. I'm just going to remind you to put yourselves on mute if you wouldn't mind, please. Thank you.
Do you know where the mute button is? Okay, perfect. Thank you. That there was also plan and conduct educational programs to meet the needs of the staff. So I'm not sure if anybody has worked with a clinical nurse or an advanced practice, an APN in your unit. A lot of units have hired them. So a lot of surgical units have hired an APN, cardiac units have the APN. So the APN is responsible for doing the rounds day to day, moving the patient through the system, making sure that nothing is overlooked, that discharge planning has been started, the medications are appropriate, that if the patient runs into a bit of a blip or a crisis, that they can manage because they have medical directives that say you can order Lasix, you can order a chest x-ray because of their role, so they can actually prevent, because by the time the doctor gets out of the OR, the patient's already crashed and burned. So these APNs can actually order these things to prevent that. The APNs are also supposed to be providing education to staff nurses as well. So while this patient is deteriorating, let's talk about heart failure. Let's look at the signs and symptoms of right and left heart failure. How can we prevent it? Blah, blah, blah. So they're responsible for conducting educational programs as well. They're also responsible for engaging in research. So, and theirs is more of the applied research. So, for instance, one of the APNs that I worked with, Tracy, she was looking at fatigue levels of patients being discharged from the hospital. So for cardiac patients, so you had open heart surgery and you have no time to catch your breath. That night you've had your open heart surgery, you are up sitting at the beds, at the side of the bed that night, you're up walking, you go up to the floor within 18 to 24 hours, then you're on the floor, you're up having your meals, you still have this big incision, you're a little bit sore, then you're doing your deep breathing coughing, so that's day 2, day 3, you're exhausted. But again, they continue to work you through, get you through the system. Day 4, you're going home. So that means you're going to get up, have a shower, take your dressing off, get dressed, get your family, get the pharmacist come in, the nurse comes in, discharge planner comes in, the doctor comes in, follow up. It is such a day of activity. It is way too much. So Tracy's her research was applied, and she wanted to know what was the experience of the fatigue level of these patients, and that's what her doctoral work was in. And they found that that was way, way too much. They didn't take anything in anyways because they're too tired. So discharge teaching had to be more beginning earlier on, but of course you had to wait till they were not so drowsy from the medication, but also that you had resources when they went home. So if you have any problems, just call me. Let's Skype. There's so many different things you can do. So really looking at that kind of applied research. Leadership. So a lot of our APNs are now advocating at higher level tables, such as the our NAO, smoking cessation. I remember Gail, our APN, she was really instrumental in getting that smoking cessation program launched at Southlake and then carrying that through back to the RNAO. And they're always available for consultation and collaboration. So if you have a patient, you're a novice practitioner, do I give the Lasix or do I hold the Lasix? What do I ask them to come and assess, and they'll do an assessment and provide you guidance. It is a specialized scope of practice. Some of them, and it's a little bit confusing because some of them have the primary healthcare nurse practitioner credential. Some are, so that means preventing chronic disease. And do you know what? That is such a brilliant job because sometimes it's just a matter of a half a Lasix one day, a full Lasix the next day to keep someone on heart failure. It's that fine titration. It's spending time with the patient so that you understand where they're coming from, and you've just found out that they're eating, you know, salty foods, and no wonder they got into heart failure. But it's the time that the nurse practitioner can spend with them to really find out, and then really individualizing that plan of care. So they're going to screen for the presence of chronic disease and monitoring people with stable chronic disease. COPD, one of my colleagues in Paris, Ontario, or in it's the hospital near there, Paris. What is it? Bransford, and there's another one. Oh, it'll come to me. And so she's the nurse practitioner for a COPD clinic, and she has her own COPD clinic. Patients come and see her. Up at Georgian, we have our nurse practitioner, Jessica Eckstein teaches this course up there, and she actually has patients rostered to her. And so this nurse practitioner role is really advancing. There are standards of practice for primary healthcare, and these healthcare settings could be anywhere. They could be rural, they could be urban, they could be community health centers, complex care. They have a nurse practitioner freestanding clinic in Sunderland, which is not far from here. And now I've heard they've developed another one just out of need, because there are such undersourced area. They have another need, so they're developing another one up near Keswick or Sutton, that area. There's such a need in occupational. Every place used to have an occupational health nurse. The schools that had a school nurse, and I see that role being really sunset, but I wonder if there isn't something else we could be doing instead of that role. I know at the hospital they still have someone who checks, do mask fit testing and stuff like that. But we need to really define what is it that nurses do, and it's really keeping the employees safe in their environment, as opposed to the employee just having the nurse. Which of the following represents the main purpose of doctoral education? And so if you said C or B, knowledge creation, you would be correct. It is B, because that's what the doctoral education is responsible for: research and knowledge, new knowledge development. So research is really, as part of the role of the doctoral education, generates, synthesizes, and uses evidence to identify and implement research. The doctoral or the graduate prepared nurse is a primary investigator, but we don't do research in isolation. If you look at an article and there's only one person, I always get suspect. What, don't they have any friends? No, but really all work that we do now is collaborative. And so I'm going to bring my expertise in simulation-based education, but I need Dr. Coffey's expertise in grant writing for us to have the synergy so that we can get some traction in our research. So never is research done in isolation. It's always collaborative. So you'll have a primary investigator. They will be collecting the data, and again, according to we talked about it, the REB, we collect data, through whatever mechanism, whether it's a survey, it's going to be a focus group, and then you're going to interpret all that data, looking for themes, and evaluating the outcomes based on that research. And then you want to critique it. Well, yeah, I felt the same thing that, whatever the research was, that this is what occurred, but also I have to realize this was a very small sample. It wasn't truly reflective of all of the students, or this was during a time of strike, so it really, I don't think it could be considered. So just because there's some barriers, we have to incorporate those barriers into the write-up, but we always want to have that at the back of our minds when we're doing our analysis. Critiques, interprets, applies, and disseminates research to all levels. And so once we have the research completed, we want to share that so everybody has that knowledge. And so you're going to disseminate that. Another part of the doctorally prepared or graduate prepared nurse is in leadership, and always looking for new ways to practice improve delivery of care. And so that's being abreast of the latest evidence, keeping on top of the latest research. It might be even the latest products. They're changing their IV pumps, so all of those really nice Baxter colleague Guardians that have been around for 15 years, they're not making them anymore. And so they've come out with a new one. It's called the Sigma pump, and it's like this big, can fit in your purse actually, which is a concern of mine. But much sleeker, but it uses the same tubing. So again, that's the way that the evidence is now changing. Or the equipment is changing. So looks for new ways to practice and improve delivery of care, conducts a needs assessment to support nurses and the healthcare team. Before I would do anything, I would do a needs assessment. And that needs assessment can be a variety of ways of doing it. So you can go to your students, and just like you go to your patients, say, what do you know about cardiac disease? And do you want to know anything about cardiac disease? So you've done your needs assessment. I might look at other benchmarks. So I might look at the NCLEX scores and see that as a general student body that there was some knowledge deficit in the area of cardiac. So then I could create some more tutorials around cardiac. Or you could see that in your area you've got a lot more fall, which is a really big thing. And so you might need to, the staff might need more education on doing falls risk prevention. This one here. So again, I think it's all about collaboration and consultation at all levels. Really, it's all collaborative. We're all part of the team. And so if there's one person that is not doing what we need to, so for instance, falls prevention, if you have one physiotherapist that leaves the side rail down or doesn't follow the plan of care, then the falls numbers will be on your unit. It doesn't matter that you were not. So we all have to be vigilant in assessing whatever the issue is or whatever the condition is. So we want to collaborate to improve quality and identify, develop, implement strategies to improve patient outcomes. Again, I can't emphasize enough, it's really taking that knowledge that the evidence is supporting, and I know that you've all been immersed in the evidence for your particular presentation, so you've gone back to current evidence, and I'm sure that many of you were quite surprised that at some of the readings that you had, you thought it was this way, but in fact it's now that way. So take that theory and now really applying it to practice. Characteristics of advanced practice nurses. So build on their expertise in a specialty area. And so they, of course, they provide excellent nursing care. That is their expectation because of their experience and their education. High degree of autonomy. So as you'll see, they work under a lot of medical directives and their scope of practice is really expanding all the time. You'll see that the surgeons are in the OR, or in the case of the clinic, that they're in an outpatient setting. Their doctors are always available for consultation, but they work very autonomously, but collaboratively. They demonstrate leadership. So they're always looking at the bigger picture. What else is going on here? Do we need to do more in-servicing on fall risk prevention? Do the nurses need more devices to prevent falls? What is it that we need here to prevent this? So really looking at leadership, initiating change to improve outcomes. So you know how we all hate to do some of these documents, so even like the brain skin score or the falls risk stuff. Some hospitals do the risk scores once a week, some do them every day. And so a lot of times you go back and you check the charts, they're not being done every day. So the advanced practice role would be to get in there and say, I noticed they weren't done, could you tell me why? And maybe it's too much paperwork. You need a simpler form to complete, or you need to have a shorter form, or what is the evidence to doing it every day versus once a week? Maybe we only need to do it once a week. Maybe we get enough data from it once a week. And so you have the ability to ask, why are we doing this every day versus every week? Or why are we not doing it twice in 24 hours? Like, why are we only doing it once a day versus twice a day? Why is it not being done every shift? So these are the questions that you can ask, and the advanced practice role should have an answer for you. Initiates change to improve outcomes, in-depth nursing knowledge, really clinical expertise. Any of the APNs I know, they have such great clinical skills. In the cardiac, they could do, oh my goodness, they could do anything. They could start IVs, insert central lines, they could adjust pacemakers because application of energy is part of their role. They have evidence-based nursing knowledge, they plan and coordinate. It's also critical analysis of health policy. So as all these health policies are coming down, are these actually appropriate? Is anybody aware of that new hospital that is opening or has opened? There was 4 hospitals that got together to decant some of their long-term patients till they get long-term care beds. And so now they're decanting them to the old York Finch Hospital. It's now, I think, it's under Humber. It's a Humber site, but it used to be called the York Finch. Have you heard that? It's going to be opening. So what's happened is that there's a lot of long-term care patients that are in the hospital that are not able to be moved into long-term care facilities for a variety of reasons. Now, my understanding, when I was in the hospital, we would find a bed in long-term care, and then they would move out to that bed. And if they didn't like that place, then they had the option of moving somewhere else from there. But I understand now they don't have to be moved into the community, into that bed. If they don't want to go to Yeehong, they don't have to go. Is that the same at your place? That's what's happening. So consequently, we're having a lot of patients that are stable, not being moved through the system fast enough, blocking beds. So now emerges are so full, they're bursting. The hospitals are funded based on those people in emerge getting out to those units. You cannot keep patients that should be inpatients in your emerge. You need to have much more efficiencies, or many more efficiencies to move them out. And so these patients, and often the frail and elderly. Did you see on TV last week where at South Lake they had them in the auditorium? They converted the auditorium. I'm thinking, oh my gosh, no oxygen, no suction, bacteria everywhere. And where are the nurses getting their education? It was always in the auditorium. So where are the nurses going? So somebody says to me, well, when you're 50 patients over census, then there's no education for the nurses. So again, so that's the sort of role for the nurse practitioner to really get these patients out. So these patients are now being decanted over to the York Finch Hospital, and nurses are being reassigned to those hospitals. So this one nurse was at York Central for 37 years, said I have to go over to York Finch now to work. And I really felt for her. I thought that's not right. So APN roles. So both roles incorporate education, research, consultation, and leadership. Those are APN roles. However, the nurse practitioner provides direct care focusing on health promotion, treatment, and management. They can prescribe and perform procedures within the legislated scope of practice. So they've got 4 additional. They can convey a diagnosis, application of energy, they can set a cast, and they can do suturing. That is all within their scope of practice. Whereas the CNS provides clinical guidance and leadership to improve quality of care in a specialized population. So pain service, the wound care nurse, that sort of thing. Just this is an association for advanced practice nurses. Just I wanted to say that it wasn't that long ago that there wasn't really an advanced practice nurse, advanced practice role. And again, I think it's because we didn't have master's preparation or graduate education. And so I want to say it's in the late 80s, early 90s when there was a pilot project and it went over really well. They lacked funding, so they said, no, we're not going to do this anymore. And then it was, I think about 1985 or 88, they resurrected another pilot project for nurse practitioners. And they said, no, we're going to keep this role going. So it wasn't that long ago that we didn't have, that this was just a fledgling role. Clinical nurse specialist, again, it's really for that specialty practice that support the ongoing development of advanced practice nursing, promote the health of Canadians. I don't think there's anything more I want to say about that. Master prepared nurses in a leadership role, they utilize evidence and theory to inform practice and apply research and generate knowledge. So clinical nurse specialists, clinical nurse experts, although I believe clinical nurse specialists and experts are used interchangeably, nurse consultants and nurse educators, they all need to be graduate prepared now. And I want to say that even managers, they need to be graduate prepared as well. And I think that's a phenomenon that just happened in the last 10 years, that more nurse educators and nurse managers are master's prepared. And I'm going to suggest that a manager doesn't have to have a degree in nursing. I'm suggesting they can have it in health policy or even business. I think it would, if your idea is that you want to be a manager, you might want to do your master's, get an MBA. I think that would be very useful in a manager role as you're managing people. And nursing has the largest span of control. So typically managers might have 35 to 40 people reporting, and then they would have their annual performance review, and they, here's a conference, I want to send you to it, I know you want to do this, or you need to do this to improve your practice. Nursing has a minimum of 200 to 250 nurses and allied health reporting to one manager. They don't even know your name a lot of times. And it used to frustrate me when I do my performance review and they would give me all this stuff. I'm thinking, you never met me before. How did you know this? But again, that was the process that I was in. So there's now over 3,000 nurse practitioners working in inpatient or ambulatory care settings. They're nurse practitioners in adult, tertiary care, or fiduciary care centers. There's also these nurses, so I always found it a little bit confusing. You're a nurse practitioner, extended care. So you have to be an extended care, extended class with the CNO to be a nurse practitioner in practice. So that's sort of how that works. And you could be a nurse practitioner in primary health care, adult, and pediatrics, pretty standard. I'm not sure what they do at sick kids for advanced practice, but pretty standard to have an NP on a surgical unit, medical unit, cardiac unit. The thing that I was unaware of was the nurse practitioner anesthetist. There's no one registered in Ontario as a nurse practitioner anesthetist. Now, I do know that there are nurses that act in the role, and they call it a nurse anesthetist role, where they help the anesthetist with delivering anesthetics. So the anesthetist goes and sets them all up, and the RN stays and calls the anesthetist when they run into problems or the case is finished, that sort of thing. So I'm thinking we need to have, and to me, that's almost like the physician assist, just extension of their hands. We need to have that rule. So I'm hoping someone in our group here is interested in being a nurse anesthetist and providing that sort of level of independent, autonomous care while being collaborative. Nurse practitioner specialties, and as you can see, every specialty is covered. There's nurse practitioners in every single specialty. There is wide distribution throughout the province, but Ontario has the most. We're also a large geographic area, and I think that they can use the nurse practitioner role in some of these underserviced areas. And even Stouffville is considered underserviced, so that you can, that's why they were able to get a freestanding nurse practitioner site in Sunderland, which is not that far either. Again, the role is really developing. And I think that it really speaks to where the needs of the healthcare needs of Canadians are. The role is really instrumental in really fine-tuning those patients. That is where, with their expertise, clinical expertise, their assessment, their ability to prescribe and diagnose, they have real ability to fine-tune those patients so that they're kept home and away from the hospital, keeping them healthier for longer periods of time. I'm going to skip the activity right now, but just for a moment, and feel free that as you're driving home, that what if you were a nurse practitioner? What would that role look like for you? Where would you work? What area would be, where would your heart's desire be? Would it be cardiac, OR? Where would be the area that you'd work? What would you like to see happen as that role? Would you like to have more of a patient influence, more of a staff influence, more of a policy influence? So what would your day look like? What would it be like to be a nurse practitioner? And I think for a clinical nurse specialist, I think that, again, that's a nurse with more advanced experience in one simple area, but be familiar with what would it be like to be an advanced or a clinical nurse specialist for pain, wound and skin. I'm just trying to think what other areas I see clinical nurse. We used to have a clinical nurse specialist for geriatrics, but I think that role again has been sunsetted, and now we're seeing nurse practitioners in geriatrics. A lot in geriatrics. Okay, so on that note, this concludes today's presentation. I want to give a sincere thank you to the people that arrived in class here. It made me feel not so lonesome. I want to thank you all for being online there. I hope that you found this really helpful to you. And those of you who will be reviewing this as a recording, I'm hoping that will be helpful to you going forward. If there's any problems with any of the recordings, just let me know and I'll see what I can do about that. I will be providing a link to everybody, and I am going to do the same thing for our Thursday class. Is that the next time we're meeting on Thursday? I'm going to do the same thing for Thursday, and I'd like to do a review class Typically, we don't do a review, but I think because the semester has been extended, I'm going to do what I never do, and I'm going to do a review class, and we'll do it similar to this on the Zoom platform. So thank you, everyone. Have a great day.
Can you hear me?
Did that work? Did it work for you, Queen?
Yes.
Very good.
Yeah, I just want to ask, we've been able to do our presentation, but there is no link for us to send it in.
Just send it to me through leslie.graham@durhamcollege.ca, and I'm going to post them for everybody in one area. So just send it to me.
Yeah, I tried, but it's saying the file is too large.
Oh, you've talked a lot.
No, it's just 15 minutes.
Okay, I will give you a link to just send me an email that you are having trouble uploading it. I'll try. Let's put it on Blackboard. Let's see if we can't get it right to Blackboard.
Okay.
All right then. Just email me.
All right. Thank you.
Thanks. Bye now.
Bye.
Okay, everyone. Thank you.